Okay, sir. Audible, sir?
Yes, sir. Please.
Audible, sir. Audible, sir.
Slide visible, sir.
Visible.
Yeah.
Proceed.
I thank my bottom of heart to Allah Environment and Organizing Committee for choosing me as a faculty inauguration first faculty. My tribute to Major Nagaraj sir. I'm missing him. He's my guide, mentor. Because of him only I developed interest in allergy. So the three people, they started allergy chapter from Hyderabad, my native place, 2010. Dr. Sukuman sir, Dr. Parmeswar, Nagaraj sir. There are three people. They are the fathers of pediatric allergy in India. They started allergy chapter. Allergy chapter increasing, growing now. Has become, as I said, adolescent now. Almost going to become adult chapter now. So I thank Sukuman sir for giving opportunity. So without wasting much time, I'm going to continue this because my topic is allergic rhinitis. As you said, allergies are increasing day by day because this allergic rhinitis, nobody will die of allergic rhinitis, but it is troubling because its quality of life is impaired. Is really create a lot of problem. So allergic rhinitis is most common form of chronic rhinitis in children, increasing prevalence, increasing day by day. Earlier, 30 years back, I went to PG, allergic is hardly used to see. Now, every second, third child is having some allergy. As Kumar said, there is a food allergy, even atopic dermatitis, asthma, allergic rhinitis, anaphylaxis increasing, day by day increasing. If you are aware, so you have good knowledge, awareness, you have good practice. Now, practice now depends upon pediatric practice. You want to survive, thrive in pediatric practice, you have three things. One is vaccination and infections, allergy. So, vaccination, government is all vaccine now. Infection, mainly viral infection, is self-limiting. So allergy, now we have good knowledge allergy, then we can thrive practice. So that's why allergy, that's why I take an interest in allergy. Even though I have good practice, I've taken interest in allergy field. I've done fellowship under Dr. Nagaraj sir, first batch, almost 7-8 years back. So the major symptom allergy rhinitis are mainly four. Well, rhinorrhea, nasal itching, nasal obstruction, sneezing. So these are three things are there. So allergic rhinitis most of the underdiagnosed. Is undertreated. Most of the time they take light. Just for surgery, the cold, they will take light. They don't get treatment. But child go on suffering. Even adults go on suffering. So untreated allergic rhinitis progress to asthma. As you said, is an allergic march. If you don't treat allergic rhinitis, you're going to asthma. Asthma is going to create a lot of problem with adult and old people also. So it affect quality of life, causing fatigue, headache, cognitive impairment because it doesn't sleep well in the night. It causes a lot of next day problem, particularly you won't concentrate, you will be always irritable because what are the incidence globally? Globally, almost 6 to 7 is 21%. Of older children, adolescents is 31%. Almost every third child is having allergic problem globally. So in India also, we are also following global incidence. Here is under 6 to 7 years, 11.3%, and 13 to 14 years, 24%. Almost every fourth child. It may be underlying, it may be every third child is going to have, every alternate person is going to have allergic rhinitis. So what are the diagnostic commonly, most of the misdiagnosis, the confusion common cold. They said common cold or sardi, just they take light. Because how to differentiate clinically common cold as allergic rhinitis and sinusitis. So duration of cold in common cold is less than 1 week usually. Allergic rhinitis persists more than 10 days. Sinusitis also persists. Onset of symptom takes few days. Common cold, allergic we can start immediately after exposure allergy. You can start instantly, immediately. A sinusitis may take few days. Treatment in common cold, symptomatic. We antipyretic, some antihistamines, but allergic they respond to antihistamine. Of course, sinusitis had to give antibiotic. Consultative symptoms, usually common cold, they may have malaise, headache, body pains. In allergic rhinitis, of course, there are consultative symptoms. They're cold, to the sneezing, I told already. Sinusitis, usually they have headache, very important. Nasal discharge, thin mucus, the common cold. Allergic rhinitis, clear discharge. And sinusitis, thick yellowish. Of course, common cold, there may be low-grade fever, maybe there. Allergic rhinitis, usually there is no fever. Sinusitis, some fever they have sometime. And pain, tooth pain, retroorbital pain, common cold, there is no pain. Allergic rhinitis, they don't have unless it is allergic rhinosinusitis. Definitely they have pain. So evolution, history, how they present. Initial cardinal symptom, I told already, sneezing, nasal congestion, nasal pruritus, rhinorrhea, commonly they have. All may not have all, but 200-300% have. But more troubling is nasal congestion because they suffer like anything. The associated symptoms they have, eye like ocular pruritus, And oral, they have oral cavity, pharyngeal pruritus, they have cough, lower respiratory, because upper airway, lower airway, both are one airway. Allergic rhinitis, they are 30-40%, they are going to have allergic asthma. Asthma patient, they have 80%, they have allergic rhinitis. They live together. Then that's why I have to look for allergic, they have to look for asthma. Asthma is they have to look for allergic rhinitis. They have nasal sniffling, sleep difficulty, 100%, particularly nasal congestion is their blockers. They are going to have sleep problem. They don't get proper sleep. So it affect the quality of life, which they feel fatigue. So they have hypoanosmia, they are snoring in the night, because adenoids, oral congestion, pruritus, the sore throat, halitosis, they have headache because they have allergic rhinosinusitis. The cognitive impairment, child cannot concentrate, cannot study in the school because it doesn't sleep well in the night. And mental problem they want to have, like feel tired because they don't sleep well, they feel tired, they feel miserable, they feel irritable, they maybe have depression also, they feel embarrassed also. So comorbidity I had to look for. Allergic rhinitis, they have comorbidity. Particularly I told asthma. Allergic rhinitis, 30% they have asthma, and they have to look for asthma. Atopic dermatitis, to start with infancy, they have started atopic dermatitis. Atopic dermatitis is a gateway to the allergic marks. They start atopic dermatitis, they go to food allergy, they develop urticaria, allergic rhinitis, asthma. And eosinophil increasing now, they are underdiagnosed. The older, more common older children, adolescents, they feel discomfort while eating. So that is a very important point. The food allergy increasing day by day because your food allergy also increasing. There's so many factors, sir. Of course, eye conjunctivitis, rhinosinusitis, turbinate hypertrophy, adenoid hypertrophy. They have hearing impaired and otitis media with effusion and gastric reflux, laryngitis. Because of this problem, they have obstructive sleep apnea. They feel fatigue. They have learning problem. They don't sleep well. They cannot learn properly in the school. So the rhinitis symptoms are more intense during early morning hours because of circadian variation. Increase of symptoms in night and morning, especially after getting up from bed, indicates a dust mite. So, because dust mite is one of the 60 to 80% of allergen in allergic rhinitis asthma because of dust mite. There's so many factors are there. So, the clear-cut worsening of symptoms in outside environment, you go out, garden, probably in morning of walking to do afternoon, you're exposed mainly because of outdoor allergen like pollens or molds. So evolution, simply see, allergic rhinitis is a clear-cut diagnosis by inspection. By seeing the child, you can make some distant allergic rhinitis. Like allergic seniors they have because of pigmentation out of the eyelids, and allergic line because child rubs, because of feel rubs, go on rubbing nose because the cartilage of bony part, this is a form of the line, allergic line, very clear diagnosis. And the allergic gap because the nose block is there, breathe through mouth. So there's an oral the allergic gap and the Denny Morgan fold. And the allergic salute. Allergic salute means this is one of the things child go on rubbing the nose. You will come to clinic, the see rubbing on it is allergic salute. The alternative the allergic rub like that. It may be allergic mannerism. It is because of to relieve the itching or to relieve the obstruction. So they also cobblestone pharynx they have. And you lift the nose, you feel hypertrophic inferior turbinate. Very simple. So you do not use any instrument, just use your finger. The hypertrophic inferior turbinate you can make out easily. They have allergic conjunctivitis. Most of the time they are associated. They have that brother. Allergic rhinitis, most of them have allergic conjunctivitis. You look eyes, they have red eyes, they will be rubbing eyes also. So most of them have allergic conjunctivitis also. So you do detailed nose examination, they have silky eyelids also. And they will be fingering the ear because there will be irritation, there may be a block of the station tube, they have gone fingering the ear. They have otitis media with effusion they have because the block obstruction station tube and long face syndrome because opening the mouth, they feel continuously opening the mouth, they will develop long face syndrome. The oral cavity, the big tonsils enlarge. So area classification, clinical diagnosis, the intermittent persistent. Rule of 4. Intermittent means symptom less than 4 days per week, less than 4 consecutive weeks. Persistent symptom is more than 4 days a week, more than 4 consecutive days. If when you call mild or when you call moderate severe, mild means all of the following. Sleep is not disturbed, no impairment daily activity, sport or leisure. You can do play, can do anything, no impairment work, school absences are not there, and symptom present but not troublesome. The symptoms, mild symptoms, are not troublesome. So there's a mild. Moderate is severe, they are troubling. One of the more, at least one or at least the sleep disturbance, they cannot sleep well. Impairment daily activity sports. You cannot go for sports activity and impair school. School absences, particularly if you develop asthma and work and troublesome symptoms. So these are the moderate to severe. This is area classification. So how to approach allergic rhinitis? The clinical suspicion of allergy is very important. There's a cold, sneezing, running, nose block, persists more than 4 days in a day and persists in more than 1 week. Definitely have to suspect. Routine test like most of the time is a clinical diagnosis. 100% is clinical diagnosis. You can observe the child from distance. You can make a sure allergic mechanism, allergic, all those things. But you can confirm by doing specific investigation, particularly where you're going to help in management to avoidance of allergen and start even specific immunotherapy also. A skin prick test is a gold standard. Do always standardized antigen should be done by expert trained in that skin test and it is available within 15-20 minutes in front of you, in front of parents. You can show them what allergy. Most of the parents say is allergic to fruits like banana, that fruit, that the child will not given apple, fruit. So you do prick to prick test also. Show the mother in front of mother, show the prick the banana, prick the child, so there is no response, there is no reaction. Then the parents are convinced. That's why skin prick test is very important. All pediatrician has to learn. Very simple if you practice definitely because future pediatric practice allergy only. You want to survive practice, you have to develop allergy interest. And also, when skin prick test cannot be done, it can be specific IgE level by immunocap. There, of course, it is costly. You cannot order more panels. Only depends upon history, what you suspect. Only 4, 5, not more than 5, 10 because it's very costly. And positive and concordant with clinical history, this is allergic rhinitis. If history and skin test positive, then you have correlate, then allergic rhinitis. But skin test positive, specific IgE positive, doesn't mean that there's an allergy to that particular antigen. It's only sensitization. So always correlate history. Take detailed history, type of house they're staying, what of cross ventilation is there or not, the mats are there, dust mite, or they have cockroach, fungus, pets there. They have to have detailed history, always correlate with whatever skin test and specific IgE, because just positive doesn't mean that the allergy. Certain foods are 10, 20 foods are positive, you cannot avoid foods. Always correlate with history, that's very, very important. Positive with discordant with clinical history. Negative means specialized allergic test. When there is a skin test, a specific IgE negative, but still allergic rhinitis is there. There is a focal allergic rhinitis, local allergic rhinitis, what is called. What test do you do? Nasal, the provocation test, allergy provocation test. This is a gold standard. A nasal IgE levels is not available in India. This is negative, that is not allergic rhinitis. The positive is local allergic rhinitis. So treatment come to the very, very important point. Once a clinical diagnosis and investigation like skin test and specific IgE, you confirm what allergen is there. What allergen is causing? Is it causing dust mite? Is it fungus? Is it cockroach? Is it your pollens? Is it your pets like cat or dog? Then if you avoidance is very important. So before that, you should know affordability, availability, accessibility, cost. Fortunately, most of the drugs for allergen is very cheap, very cheap. And you should know how to tailor the requirement. Is it mild, moderate, severe, persistent, with associated comorbidity, asthma? You have to decide then what treatment to give. If you do skin test and avoid allergens, very important. First step is avoidance allergen irritation. Then go to pharmacotherapy. So depends upon the severity. If it's mild is there, give just antihistamine. So antihistamine I'm going to discuss what antihistamine to give one, how long to give one. That is very important. Before that, patient, parent education very important. Tell them this is allergy. It's going to persist. Allergic rhinitis is not going to disappear like common cold. It's not going to subside. It persist unless you control the allergens, avoid the allergens. Tell them and adherence to technique, particularly moderate to severe. Then we have to go in an international steroid. We have to tell the technique and tell the duration is very, very important. Look for complication also. Monitoring is very important after every treatment. Follow-up is very important. First visit, you have to explain, counsel properly. Otherwise, go on shopping different doctors. Again, they come to you. You tell them this is allergy. It won't subside unless you avoid, unless you treat properly. Then your quality of life improves. Child have good sleep and good education. Otherwise, you're going to affect the quality of life. You won't sleep. You affect cognition, learning. So your life will be troublesome. And monitoring is important. This is very, very important. Then, of course, no improvement in the treatment. whatever all treatment you have given, there is absolutely no improvement. The parents are fed up with, they want permanent cure. Of course, definitely the permanent cure, particularly immunotherapy is available. So that particularly immunotherapy is very, very important, particularly the pollens, dust mites, very effective. Others, particularly fungus, this is not that effective. It is done by standardized and it is done by expert allergy specialist. Parent education is very, I told you, parent, patients, the older child should be educated about the nature of allergic disease, likelihood disease progression, need for long-term treatment. Tell them the long-term treatment. It persists. Allergy rhinitis won't disappear. It won't disappear. It may persist throughout life also. Hardly 5-10% may they may remission, which is very rare remission. So that's very important. But I have to explain to them. Discuss about safety and treatment modality. Every visit you have to explain the method, how to use the medicine. Explain about the need for intranasal steroid, eliminate the fear of steroid. Some parents, because they have Google, internet, they say steroid. Steroid, they're afraid of steroid. No, don't use steroid. They're afraid. They say local action doesn't have side effect. Very safe medicine. We use properly. Technique has to be explained. How to use. This is very every visit have to see the how you are using properly. There's wrong technique, wrong adherence, not using properly. Definitely the symptoms won't subside. That's a very important point. Importance of complaints is very, very important. And explain about the avoidance of triggers. Every visit tell about triggers. If we do skin test and specific eyes, you know what allergen is causing. If you avoid them, definitely they can the symptoms decrease. Very important. If you don't avoid triggers, if you go on using medicine, you're going to suffer. Educate about the technique and device each time. Each visit, tell them how they are using in front of you. Demonstrate in front of practitioner. Because the after nostril, this is the nose, the tip should be towards eyes and ear, not towards septum. Because if septum it may cause the damage, bleeding also, perforation septum. So education to be tailored to need of the patient. Discuss about the parent goals expected, what they expect. This is very important. So allergens and irritants, avoid, I told, very, very important. Common allergens are 60, 70, 80%. Dust mite, very common. Dust mite is main allergen in our country, indoor allergen. Cockroaches, so, and also fungus. Leaking wall is there, the fungus. Pollens outdoor, the outdoor pollen allergen. Pets, of course, avoid pets, cats, dogs in your bedroom, child bedroom. Of course, food also can cause allergic rhinitis. And irritants, they are not allergens, but they exasperates. Irritants are very important. Exaggerate 10, 20 times more. Was it tobacco, muscular repellents, disease, automobiles? The air pollution is increasing. So I told you, air pollution, the allergy is called twin brothers. Air pollution exaggerate allergy. Allergen just won't increase the allergicity, but with air pollution, pollutants, irritants, it increase 10 to 20 times. That's a very important point. But irritant to be avoided. Come to oral antihistamines. First generation oral antihistamines should not be used is because it causes a lot of side effect. Should be used. The high flame is short 2-3 times. Lot of sedation. Excessive drying mouth, and child cannot concentrate in school. He gets sleepy. Decrease REM sleep. First generation antihistamines should not be used. Second generation antihistamines is very important. They are greater selective for peripheral H1 receptor. Second generation preferred due to favorable safety, efficacy, and ratio. Then OD dose and additional anti-inflammatory effect. Fexofenadine, belastin, they are non-penetrative. They are non-sedating. Particularly belastin required above 6 years. Fexofenadine can be used above 6 months also. So even other drugs are just loratadine, levocetirizine, cetirizine. And you can give given from 6 months onwards, except loratadine, they are given after 6 months. Sebastian, belastin given from 6 years, rupatadine given above 12 years. So fexofenadine is having additional anti-rhinoviral property. That's very important. Effective for all symptom allergic rhinitis, including ocular symptoms due to allergic rhinitis. That reduce the emergency visit, hospitalization, and stuff. So mild allergic rhinitis, antihistamine, a drug of choice. If it is not improving, then how to you can start to international antihistamines are available in the market. Azilastin, holotriptyline. Azilastin problem is taste. Now the market is available in combination with steroids. Decongestants should not be used long term. Maybe short term. There is sinusitis is there, discomfort is there, nose block. They can use 2 to 3 days, but should never be used long term because a lot of side effect, lack of cardiac complication. You can get rhinitis medicamentosa. is very important. This should not be used long term. And intranasal steroids is the gold standard. Moderate to severe, no response to antihistamine or inhaled antihistamine. Of course, main treatment moderate to severe is intranasal steroid. Intranasal steroid is the most efficacious medication available for treatment of allergic rhinitis, effective for all symptoms, particularly blockers, congestion, very important. Antihistamines are useful for runners, itching, but sneezing. But blockers, antihistamines, not much useful. That's why intranasal steroids are very, very important for blockers, because blockers people they suffer a lot. They don't get good sleep. So if nasal congestion is the predominant symptom, the persistent type of intranasal steroid is the drug of choice. This is gold standard. So current intranasal steroids are well tolerated, can be used on long-term basis without side effect, can be used for months together. Minimum you have to use 3 to 6 months. Then if it is responsive, you can stop, or can use before monsoon season where there is more exacerbation, the seasonal rhinitis. Therapy failure is often due to poor compliance. They don't use. They are fear of steroids, the wrong technique. They are using empty inhaler, empty gun is pushing like that. The wrong technique is very important. That's why you have to check the technique every visit. So how they are using. Compliance is very important. So new generation intranasal steroids can be used safely. There may not be an increased risk of intraocular pressure or HPA suppression for prolonged use. Technique has to be checked every visit. So intranasal steroid with low system viability, very safe, particularly mometasone, fluticasone 48, fluticasone propionate, their bioavailability, serum systemic viability is very low. Local effect is there. The very, very good response, particularly fluticasone 48 has higher GC glucocorticoid receptor affinity, protein, therefore the dose is very less. So the technique has to be used. The side effects are very less. There are 30% that deposit in the nose, 70% the solid, they will bypass hepatic metabolism. The side effects are very, very less. If you use properly, most of the time side effects they only because wrong technique. The eye side effects are very, very less. Very less. Glaucoma, I have to look for, of course, long term, look for glaucoma and cataract also. You have to take ophthalmologist opinion whenever necessary. So Montelukast, role of Montelukast, no role, not recommended, no monotherapy of Montelukast in allergic rhinitis. Allergic Montelukast used when allergic rhinitis with associated asthma. And very rarely there's obstructive sleep apnea may be used with Montelukast may be used. But Montelukast, because of now recently FDA approved said not to use children because of lot of psychological problem. They have suicidal tendency reported because of side effect. They're very cautious. Earlier used to do left hand like paracetamol used to use very right Montelukast. Any allergy use Montelukast for months together. Parents should take Montelukast combination with antihistamine. Antihistamine, Montelukast antihistamine should never be used. Combination is banned, should not be used because on acidic and alkali effect is less. That's why it should not be combined. Montelukast used separately, antihistamine used separately. Montelukast has no role in allergic rhinitis, provided it has causes asthma or rarely used obstructive sleep apnea. Saline nasal irrigation is very, very effective. Approximately 50% patients are allergic rhinitis. Those who have long-standing symptoms, those are post-nasal drip, particularly takes away, clear the allergens, and where it should be use saline irrigation before steroid medication. It's very effective, very cheap also. Probiotic, of course, recently a lot of probiotic, of course, because as you know, gut microbiota, gut microbiota develop first 2-3 years, first years life, like brain develop first 2 years, and gut microbiota also develop first year. Then dysbiosis, use of more antibiotic in first year. So definitely the dysbiosis, that may be the reason for the children developing allergy disease. That may be the gut microbiota is defect, dysbiosis. That may be one of the reason for the hygiene hypothesis, so food factors, modern lifestyle, so many factors are there. Now, recently a lot of studies are going on probiotic. They're not proven useful in allergic rhinitis, but if you use early, the dose, different what strain, use early infancy, there may be definitely benefit in atopic dermatitis, but not proven allergic rhinitis. So, of course, omalizumab, anti-IgE is used, definitely recommended asthma, not responding asthma, but allergic only purely allergic rhinitis is not recommended. If it is having troublesome allergic rhinitis with asthma, definitely recommended. Above 6 years, definitely decrease the quality of life. Is dramatic improvement is there, but main problem is drawback is omalizumab is high cost factor. Can be used after 6 years associated with bronchial asthma only, but not only allergic rhinitis is not recommended. Allergic specific immunotherapy. When child they are using all medication and they are using intranasal steroids, antihistamine in combination with antihistamine, the nasal saline irrigation, avoidance allergen. Parents are fed up. They're troubling. Sleep is affected. The parents they want permanent treatment. Kuch hai doctor kuch karo. So there definitely there is role of allergic specific immunotherapy in severe, moderate severe allergic rhinitis. No response to medical therapy is important because the increasing dose of allergen extract is used to allergic patient to ameliorate the symptom associated with the subsequent exposure to causative allergens. Definitely there is a response, particularly if you use standardized allergen, particularly very useful, particularly allergen is dust mite and pollen. Definitely. If you're not able to avoid the allergen, not responding to your routine medical treatment, child's quality of life affected, is suffering, definitely allergen specific immunotherapy is a permanent cure. Even after the main problem is immunotherapy is long course. It has to use intensive phase first 3 months, maintenance 3 to 5 years. But advantage is after stopping immunotherapy also for many years, 10 to 20 years, they never develop allergy. They are relieved for allergy symptoms. There may be one of the only permanent treatment available, allergen specific immunotherapy. But should we use a standardized allergen? Very, very important point is monitoring. By every visit, you have to check, treat according to control of allergic rhinitis. Last added drug to be withdrawn to the step down therapy. Improvement is a decrease the last drug. Stop it. Monitor side effects of antihistamine, intranasal steroid, and immunotherapy. Antihistamine very safe. Second generation, you can use double, 4 times. In urticaria, you use 4 times drug. No side effect. Absolutely. First generation never use. Second generation particularly very useful. And particularly fexofenadine and belastin, they doesn't have any sedative effect. And follow-up visit should be done once in 15 days unless control is achieved. Then later once in 3 months. But that's very important. Follow-up is important. Check for the adherence. Compliance important. How is symptomatology? Quality of life improving and growth also monitor children on intranasal steroid or other steroids are using, particularly atopic dermatitis, conjunctivitis. Techniques of intranasal steroid inhalation to assess every visit. Ask them to bring inhaler, demonstrate in front of you how they are using. They are using, sometimes they may be inhaling deeply because medicine is going down. They may be exhaling down. That is important. How slight neck flexion and tips should be in the nose, right hand, left nostril, left hand, right nostril, tips toward the eye, and one should not take deep inspiration. That is very important. Surgery, allergy rhinitis, most of the time, ENT surgeon, they go to adenoid, tonsils, so the allergy, they suggest surgery. So surgery indicated only there is no response to medical treatment. In spite of adequate medication, nasal block is continued to be problem. Patient should be evaluated by otolaryngologist for septal deviation, adenoid hypertrophy, infiltrate hypertrophy. If it's troubling, sleep is trouble, snoring is there. With the international steroid technique is correct. Adherence good. He's having addition to antihistamine with international steroid and antihistamine are using, saline irrigation are using, probiotic are using, everything is used, but still troubling. Nose block is there. Definitely, he may need surgical intervention by otolaryngologist. Stepwise approach summary. So every step there has to rescue, treat, medication, nasal decongestant, intranasal anticoagulants very rarely used. Severe anuria may be used. But any step can up and down and check the inhaler technique. I told you every visit at check inhaler technique, adherence to therapy or not, an anatomical abnormality before considering step up. Because nasal block is there, they have to look for that also. Step 1, avoidance allergen triggers. Very, very important. Allergen, avoid 50, more than 50% you can control it. Step 2, non-sedative antihistamines. Second gen antihistamine, particularly fexofenadine. And step 3, intranasal steroids. If no response to antihistamine, intranasal steroids are important. If intranasal steroids no improvement, you can add intranasal antihistamine. And if no improvement, you can go nasal saline irrigation along with intranasal steroid, intranasal antihistamine. Of course, last is there. Of course, very severe rhinorrhea. Intermittently can give epitropium, anticholinergic drug also. Montelukast should be added only associated with asthma, not only rhinorrhea. Only allergic rhinitis, montelukast is not recommended. Of course, eye involvement is there, antihistamine to eye drop may be used because most of the time allergic rhinitis is associated with conjunctivitis also. So, of course, last is allergy specialist opinion to be taken for role of immunotherapy and omalizumab. Omalizumab and immunotherapy should be given by allergy specialist after other medical treatments are failed. Summary: allergic rhinitis is common chronic respiratory disease. One is common troubling. This is suffering. Every second, third, fourth child or adult is suffering this. Most of the practitioners misdiagnosed as common cold. They are not even proper treatment. They are not spending much time with patient, explaining about the important. They are just telling mild, sardi hai, chalo. Now they're telling very light, but they're suffering. Fexofenadine, Velastine are the two antihistamine divide up sedative effect. Because particular children, they are studying. The academics is important. They have sedative antihistamine. They cannot study in the school. They cannot concentrate. They affect the quality of life also in the academics. Intranasal steroid is a drug of choice, is gold standard for moderate severe allergic rhinitis and for a blocker, particularly blockers. Antihistamine very useful for runners, sneezers, but blockers, main drug is intranasal steroids. Every technique, every visit, explain about how they are using. Adherence should be checked. Their doubts should be cleared, and they keep and whatever doubts they have explained to them. No role of montelukal allergic rhinitis without asthma except obstructive sleep apnea allergic rhinitis. Immunotherapy is effective in allergic rhinitis who are not responding to pharmacotherapy. All medicine are used. Technique is correct. Everything is correct. Avoid allergens. Everything correct. But the last resort is immunotherapy. Thank you, sir.
Thank you, Narayana Reddy sir, for that excellent talk. Actually, there's nothing more to add. You have covered all the aspects of allergic rhinitis, and it is actually a very important topic also because in Kerala, according to IAP President's Action Plan, there is a plan called aerosol therapy, and in that we have included a video on how to use a nasal spray in allergic rhinitis. So thank you, thank you, Narayan Reddy sir. And just one more thing to add, you are from Telangana, and I had a friend who used to develop allergic rhinitis, and whenever he used to have this Hyderabadi biryani, just because of the smell, he used to develop severe allergic rhinitis also. So,
Irritant.
yeah. So thank you, sir. Thank you so much. We'll come to the questions later due to lack of time. So the next topic is about food allergy by Dr. Narayanan Prasad Modi. Dr. Narayanan Prasad Modi is a very well-known speaker to most of us. He is currently the Associate Professor of Pediatrics, SCB Medical College, Cuttack, and he is a speaker in various national, state conferences, allergy, asthma, respiratory forums, and he is the author of many chapters, and he has also 5 international and 4 national publications to his credit. He's also an EB member in IAP National Respiratory Chapter, IAP Allergy and Immunology Chapter, and currently an EB member from Odisha, CIAP. So over to you, sir. Naren Modi, sir.
Thank you, Dr. CB, and deeply grateful to IAP State of Kerala, Environmental Chapter, Allergy Immunology Chapter, and Central IAP. We'll straight go to the topic proper. I have been given this topic of food allergy and sensitizing ourselves for this presentation. The huge topic, and more than that, the controversial one, because in any discussion on allergy, questions about food allergy are the maximum. So it was a great challenge to squeeze this food allergy sensitization in 20 minutes. At the same time, it's a privilege also, because nobody knows much about food allergy. So it was a blessing in disguise. Thank you so much. Yes, it's a double-edged sword. To start with, to tell all of my esteemed delegates that food allergy is a double-edged sword. We come across it and we miss it also. It's both an underdiagnosed and overdiagnosed problem in our day-to-day clinical practice. Why we are discussing this? Just now I told it's both a underdiagnosed and overdiagnosed problem. It's an early life problem. It starts early because we know very well the atopic march, all of us. and the prevalence is rising actually. It can be potentially life-threatening, and usually in our practice we do blanket ban on foods, which is hugely detrimental to the health of the child. What is the scope of a food allergy discussion, starting from definition to prevalence, clinical problem, history, diagnosis, management, to the recent advances and take-home message. What we are not going to discuss here is cell-mediated food allergy, allergic contact dermatitis, non-immune adverse food reactions, detailed management of food allergy, specific immunotherapy, recent advances and controversies. We are not going to touch upon now due to want of time. How we define food allergy? It's an adverse health effect arising from a specific immune response. It has to be immune, either IgE or non-IgE or mixed variety that occurs reproducibly. It has to be consistent with the same food over and over again on exposure to a given food. And the exposure can be in multiple ways, even through skin, not only through the oral pathway. Now, to talk about prevalence. Yes, prevalence is rising because of many factors. Nothing is established for sure yet. Diet, lifestyle, awareness, maybe more of diagnostics. The clinical manifestations, they are increasing. Severity, increased risk of persistence into later stages. And food allergy is anything between 1 to 7% of the total number of allergic manifestations in different geographies all over the world. A study from 2004 said that in Americans, its prevalence is around 3.5 to 4%. Yes, in eastern region of the world, the food allergy prevalence and incidence is less than the western world. And a landmark study from my guru, Dr. P.A. Mahesh from Mysore, told that in India, obviously the test, of course, the test was in adult, the prevalence of probable food allergy was only 1.2%. From that, cow's milk protein allergy 0.5 and apple probably 0.5%. Yes, of course, it is low. Maybe we don't know, maybe we ignore, maybe we don't diagnose. But even the data are also not robust and compiled, but still it is low, but increasing in our country also. It can coexist with asthma, atopic dermatitis, allergic rhinitis. Yes, the incidence and prevalence is more in atopic children. About 1/3 of moderate to severe atopic dermatitis, they have IgE mediated food allergy. And around 6 to 8% of asthmatics, they have food induced wheeze. Now, what are the factors that contribute to rising food allergy prevalence? These are all this funniest, fantastic, fantasizing hypothesis, starting from modern lifestyle, dietary factors, hygiene hypothesis, food processing hypothesis, to increased use of PPIs and genetic factors. They are all hypotheses at present till now, but nothing has become a theory, but they are all have scientific basis, which we are yet to prove for sure. Genetic factors is a very, very important contributing factor. Null mutation in filaggrin genes, genetic predisposition and family history, and association of HLA alleles in food allergy. What are the common food allergens? 8 foods in the world that contribute to 90% of the food allergy prevalence. And most importantly, milk, egg, nuts, and fish and seafoods. The most intriguing part of food allergy is hidden allergen, because we don't know that this particular food is there present in that particular preparation or not. So hidden allergens are a difficult part. They don't enable us to include or exclude a particular preparations. We need to go into the detail of that particular preparation. So they are all difficult part when we wish to eliminate a particular food. And these are all the common food allergens present hiddenly in all these preparations. Cross reactivity is another big problem in food allergy and the elimination of food, that particular food from the diet. Ragweed has a cross reactivity to all the melons, birch pollen to carrot, apple, hazelnuts, and potatoes, and banana significantly to latex. And if a person is particularly allergic to one shellfish or legume, he is likely to be allergic to all the varieties of shellfish and legumes. These are different case scenarios in my personal practice, which we will not discuss because of want of time. We had a case of non-IG mediated food allergy, then a classical food allergy, then a food intolerance, lactose intolerance case. These are the different classifications, types of food allergy. More importantly is IG mediated food allergies. It can present as an anaphylaxis, pollen food allergy syndrome, otherwise called oral allergy syndrome, food induced asthma, food dependent exercise induced anaphylaxis, a really fatal one, food induced urticaria with or without angioedema, food induced rhinitis. A mixed variety is also to be actually considered, in that atopic dermatitis and all the upper GI problems, esophagitis, gastritis, the non-IG mediated. We have a fatal one there also, protein-induced enterocolitis syndrome. This is one of those non-IG mediated which can occur in few minutes to hours. And all other forms, they are sort of insidious and chronic onset. They just take time to evolve. What are the clinical features of IG mediated food allergies? See, these are the different systems which are majorly involved. It is not only GI tract or not only skin that we will look for. These are the common systems. We have constitutional symptoms, general symptoms like anaphylaxis, dizziness, fainting, itching, chemosis, and cramps also. Mind you, not a single system manifestation will make us suspect about food allergy. It has to be more than one system, either a combination of GI or skin or respiratory plus GI, more than one. But that one common denominator is a GI manifestation in food allergy. It has to be above and over GI manifestation. Non-GI mediated food allergy, majorly GI manifestation. To add to it some form of skin presentation like exacerbation of atopic dermatitis is the most studied one. Some purpura, contact dermatitis, exacerbation of photoallergic reactions, dermatitis herpetiformis. Others, a chronic insidious onset anemia also is one of the feature in non-IG mediated, because they will have a lot of this mucoid bloody stool for months and years. Non-IG mediated food allergy, these are the classical ones. Food protein induced enterocolitic syndrome, I just now told, it can occur in minutes to hours. One of those fatal varieties, rapid progression. This is allergic proctocolitis, a less faster one, and food protein induced enterocolitis. They are all restricted to the lower GI like colon and rectum. Non-IG food allergy, it has some classic feature, some characteristics. This occurs early in infancy. GI only sign symptoms may be there. So IG mediated food allergy, one common denominator GI tract, one at least another one plus GI. But non-IG mediated food allergy can be specific to, can be confined to a GI manifestation. Failure to thrive is one of the Hallmark of non-IgE mediated food allergy usually outgrow by 1 year, usually single food allergy, no other atopy or allergy, and absence of family history of atopy. These are the characteristics of non-IgE mediated food allergy. What are the food allergy mimics? The most classical one is a food intolerance, lactose intolerance, and it can be food poisoning, gluten sensitivity to irritable bowel syndrome. Now, how to differentiate between a food allergy and food intolerance? Many of us, we all know type of reaction. Here it is immune mediated, this is non-immune, metabolic. Usually onset of symptoms within minutes to hours. It's gradual. Any age is food intolerant age, but food allergy usually childhood. We'll discuss again. Small amount can cause food allergy, and diagnostic tests, skin prick test, serum specific Ig, oral food challenge, they are specific to food allergy diagnosis. Food intolerance, we will have elimination of suspected diet, hydrogen breath test. So these are all the differences between food allergy and intolerance. How to diagnose? Symptom signs within minutes to a few hours. It has to be there. And it has the presentations may vary, but it has to come with that particular food again and again. It has to be consistent. The presentations should be reproducible. Elimination should give relief. Reintroduction, recurrence of signs and symptoms. So these are the hallmarks to suspect clinically a food allergy situation. Sign symptom, as I told, has to involve GI, gastrointestinal tract. Evidence of atopy may or may not be depending on IgE mediated or non-IgE mediated. In history, what we need to gather? Onset, timing, spectrum of presentation, duration, consistency, frequency, food quantity to treatment given, the response, and family history of atopy. And whether exercise was needed for sign symptoms, that will tell a lot about the impending anaphylaxis or a means expectation of anaphylaxis followed by intake of food and exercise. Specific Ig for suspected food. Food diary, that is one very critical window on the part of the parents to take and present before the physician. Elimination test, double-blind, placebo-controlled food challenge, that is the gold standard to diagnose a food allergy, but not very clinically feasible. Mast cell tryptase, GI endoscopy has got very minimal role. Food diary, what we need to take? Detailed food intake of last 1 week. Detailed, we have to give time. Signs, symptoms, onset, duration, presentation, and correlation of that particular food to the presentations of signs and symptoms. So these two are the very vital part of a food allergy diary. They will enable us to think about prick skin test, serum specific Ig, or challenge test, or elimination. So these two, unless we have these two, we can't practice these two things. Now coming to skin prick test and serum specific Ig. Tests for food specific Ig are recommended to assist in diagnosis. We don't prescribe food panel tests without history, because the study told that they will lead us to a lot of misdiagnosis. Specific Ig in the form of SPT or immunocap, highly sensitive, moderately specific, lot of negative predictive value, but positive predictive value is less than negative predictive value. Ig mediated, now it's a rapid screening test to resort to skin prick test. As I told, a negative predictive value is lot, more than 95%. Absence of SPT sensitivity, almost we can rule out a particular food hypersensitivity, but it cannot rule out clinical reactivity. High degree of clinical suspicion, use further diagnostic test like a serum specific IG or intradermal prick test, which is usually not practiced in food allergy situation, or a challenge test. Serum specific IG, this is the hallmark. Immunocap, most diagnostic. Again, a high positive predict and a negative predictive value. No large panels, as I have already told. Cutoffs are useful to determine whether an oral food challenge is warranted and to advise to counsel patients and parents. These are the positive predictive threshold of immunocap. Egg in infants less than 2 years and more than 2 years. Milk in less than 2 years and more than 2 years. Peanut, fish, tree nut, soybean, and wheat. These are all the serum level of specific IG against these particular foods to have a cutoff value, to think of whether the particular child or patient is sensitive to that food. Oral food challenge has got a less of role in a day-to-day clinical situation. It determines clinical reactivity when the history gives a lot of suspicion, but specific IG or prick skin test is negative. To know oral tolerance during the follow-up of food allergy patients over the time or after oral immunotherapy. When we introduce a new food in a sensitized child, we can resort to oral food challenge. To know what is the initial dose of oral immunotherapy, oral food challenge is one of the ways. As I told, double-blind placebo control is the gold standard for diagnosis, and controlled food challenges should be practiced in a hospital setting with all the backup of resuscitative measures. In natural course, as I told, that around 3/4 of the food allergies the child outgrow by 6 years. And these are the different ages by which these food allergies is outgrown by the child. Hence, egg white by 7 years, cow's milk by 5 years, almost 80% of the cow's milk protein allergy is outgrown by 5 years. Peanuts, all the nuts and shellfish, they are the persistent variety of food allergy. A child usually doesn't outgrow against all these foods. How to prevent? These are the different modalities to have a preventive strategy to food allergy. Exclusive breastfeeding for first 4 to 6 months and to be continued till after 2 years. Infants with family history of atopy and extensively hydrolyzed formula for possible prevention of atopic dermatitis and cow's milk allergy. If exclusive breastfeeding is not possible, we have to give extensively hydrolyzed formula or amino acid formula. Manipulation of mother's diet during pregnancy, lactation, or restricting allergenic foods from infant's diet will not prevent development of food allergy. This is one thing we must remember for our practice and counseling to the parents. They will have a lot of queries about this. So please, there is no rule as of now to have restriction on food during pregnancy or lactation for prevention of infants' food allergy. Pre-probiotics roles are still inconclusive as far as food allergy is concerned. Education about food avoidance is key to prevent reactions. Education is the key. To give time to the parents and the child is the key. Inform about label reading and cross contact of allergens. They have to be told little bit of about these two things. Not delaying solids after 6 months of age. One solid to be introduced at one time after 6 months for complementary feeding. Always carry adrenaline if there is a lot of atopy in the family, the child is personally atopic, the child has had a previous anaphylaxis. So to carry adrenaline is one of the better practice to prevent food-induced anaphylaxis or fatality. Establish food allergy and anaphylaxis network That is a huge practice in Western world, yet to gather momentum in our country. Egg allergy, immunized with influenza vaccine containing low dose of egg protein. So these are the preventive strategies for food allergy. Approach to winning, this is a tailored one for prevention of food allergy. This is a wonderful one. If the family has no allergy, approach to winning is anything can be given, outcome will be healthy. Mild allergy, early exposure to allergens. We'll come to that in the next slide. Outcome will be healthy. Moderate allergy, avoidance, early immunotherapy, outcome will be healthy. Severe allergy, anything we do, the outcome will be the child will be allergic. So these are the different strategies for winning. Current IAP recommendation, we have already discussed exclusive breastfeeding for the first 6 months, and introduction of solids should be delayed by 4 to 6 months of age. Experts that tell introduction of solid foods, including potentially allergenic foods, should not be delayed after 4 to 6 months of age. Controversies, early or late introduction of allergenic food. Landmark study, LEAP study, it said that early introduction of peanuts significantly decreased the frequency of the development of peanut allergy among children at high risk for this allergy and modulated immune response. They induced oral immune tolerance against peanuts. So early introduction is the key, but not before 4 to 6 months, but no restriction after 4 to 6 months. It's a landmark study, revolutionized our approach, our thought about induction and prevention of food allergy. A gastro cohort study from Singapore, it told that if the basic prevalence, the fundamental prevalence of food allergy is less in a particular geography, so they will have less of food allergy, even if we introduce that particular allergenic food. Australia, one intervention study on early egg administration was done. Introduction of cooked egg at 4 to 6 months of age might protect against egg allergy. So it was published in 2010 JASI. So there is a shift from a passive avoidance of responsible allergen toward a proactive tolerance induction strategy, which is classically termed as dual allergen exposure hypothesis. How to manage avoidance, that is one of the management strategies. That is the key management. Here, prevention is the treatment in food allergy. So no food could be the treatment of acute severe reactions, of course. We have to have all the measures in our facility to tackle anaphylaxis. We have to educate how to tackle anaphylaxis to the parents. Supported treatment like fluids, antihistamines, corticosteroid, new treatment of food allergy, oral, sublingual followed by oral or epicutaneous immunotherapy, hydrolyzed formula for the infants at risk, complementary foods not to be delayed beyond 4 to 6 months, pre-probiotics, anti-AG, Chinese herbal formula 2, these are all in still experimental stages. Food dependent exercise induced anaphylaxis, avoid food ingestion within 2 to 4 hours of exercise. This is again one of the management strategy, again a preventive strategy for food allergy. Targeted or empiric food elimination diets or amino acid based diets for successful esophageal esophagitis, eosinophilic esophagitis therapy, and swallowed topical esophageal corticosteroids for successful eosinophilic esophagitis therapy or oral steroids. So these are all different management strategies in different clinical situations of food. How to approach IgE-mediated food allergy. This is a flow diagram starting from a detailed history, focused physical examination to skin test specific serum IgE, and if positive, then we have to correlate with history. If negative, and then following on suspicion, we have to have a elimination strategy. So this is the flow to approach IgE mediated food allergy. Prognosis: non-IgE food allergy resolve more quickly than IgE food allergy. Most children with food allergy eventually tolerate milk, egg, wheat, and soy, except those nuts and shellfishes. Regarding milk, early studies suggested resolution rates of approximately 3/4, 4/5 by age 5 years. Wheat, they are outgrown by 29% by 4 years and 70% by age 10 years. Allergies to peanut, tree nut, fish, and shellfish persist more often. Taking home, food allergy is increasing, but still not much in Asia. Suspicion is the key. A focused, detailed allergy history, clinical history, examination, they are the keys to pick up food allergy. Prevention is possible, different strategies are there. Blanket ban of foods, a strict no-no. Like a food panel test is a strict no-no. Blanket ban of foods is also strongly to be condemned for all of us. Peanut allergy, highest mortality and maximum persistent through life. New types of immunotherapy is a must, like oral immunotherapy and epicutaneous immunotherapy. We have to be open-minded. We cannot close and do blanket ban, recommend and prescribe food panel tests. So we have to keep our minds, ears, eyes, brain open. Patients, families, physicians need to be educated about food allergy. Education is the key. That is the power. Thank you so much. Thank you.
Thank you, Narayan Modi sir, for that, for making that complicated topic a very simple one, and for everyone to understand easily, because food allergy is always, at least sometimes, a headache for the treating pediatrician and allergist. Actually, there are a lot of questions in the chat box, and due to lack of time,
I will answer in the chat box.
Yeah. I think it's we would humbly
That
request
will be
the
prudent,
speakers
and
to.
that will save us a lot of time.
Yeah.
I will answer. I will give my mail ID, and we can always discuss. No problem.
Okay, sir. So thank you, Narayan Reddy sir and Narayan Modi sir, for that excellent session. Now I hand over the mic for starting the session 2 to Dr. Bennett Salem and Dr. Hari Kumar.
Thank you, CB and KM, for that excellent moderation. Now over to the next session, moving on from allergy to the environment. Now I would invite Bennett sir and Hari Kumar sir to moderate the next session. To begin with, we have Dr. Ramesh Bajania. I would like to invite Hari Kumar sir for introducing sir and carry on with the session. Over to you, Hari Kumar sir.
Thank you, Jijo. At the outset, let me thank Pathanamthitta branch and the organizers of Alar and Mikon for giving me such a wonderful opportunity to chair a session. That also, the speaker is none other than our national chairperson of ECHG. So climate changes and how the changes affect children is a very hot and live topic, and we are living in an era of global warming, and we know many allergic diseases are seasonal, and how the changes in environment, pollution, etc., affect the child's physical and as well as mental health is a topic of paramount importance. And to talk on this topic, we have a speaker, Dr. Ramesh Bajania sir. He's the national chairperson of PCHG, and he has become a household name in Kerala IAP circle. He's a regular speaker in many of our conferences, and he, recently, some 2 days back, we had a talk. He had a talk in Vadagara IAP on breastfeeding, and Dr. Ramesh Bajan is from Mitrag Child Hospital in Junagata, and he has organized many state and national conferences, and was the organizing secretary of AIOP Gujarat in 2010, and a regular faculty in national pedicons since 2014. So with great pleasure, I invite our national chairperson, Dr. Bejania sir, to for the talk. Uh, Thank you, sir. So please take over.
Good morning to all. Hope I am audible.
Yes, sir. Yes, you are audible.
Yes. So thank you very much, Kerala IAP branch, our own environment and child health group Kerala, and allergy and immunology chapter. Now, global warming of late, we all read in newspapers, see in channels, see in YouTube, because it is making headline. So what is global warming? It is an increase in the average temperature of the Earth's atmosphere and mind well oceans too. Global temperature on both land and sea has increased by 0.6 degree plus or minus 2 degree over past century. Now, there are so many causes, but anthropogenic and natural broadly divided into two. Anthropogenic is man-made and natural are related to nature. As we know, man has need, but the need is beyond greed. Man is exploring oceans, exploring earth, oil and gases are removed from the earth's core. This has led to decrease in earth's magnetic field, nearly 10 times faster. So earth is being pulled closer to sun, and that is why increased solar activity leading to global warming. It may weak earth's magnetism affects eccentricity of earth's orbit. That is why we see unequal distribution of solar energy and extreme weather conditions. The important gases are methane, carbon dioxide, nitrogen dioxide, CFCs, and so many. Now, how does the greenhouse work? We all have heard the greenhouse effect, but what is greenhouse? Greenhouse, as we have seen so many times, it's a building with glass walls and glass roof. Greenhouses are basically used to grow plants such as tomatoes and tropical flowers. It stays warm inside even during the winter. In the daytime, sunlight shines in the greenhouse and warms the plants and air inside. And at night time, it is cooler outside, but the greenhouse stays pretty warm inside. That is because the glass walls of the greenhouse trap the sun heat. This all must have seen during that trip to abroad or at national places. Similar is the mechanism of greenhouse effect. The greenhouse effect was much the same way on Earth. Here, the sunlight enters the Earth. Some of the energy is absorbed, some energy is released back into the space. But the presence of greenhouse gases that trap this heat. That is why the atmosphere around Earth becomes warmer. We all know carbon dioxide, methane, nitrous oxide, hydrofluorocarbon. To know the sources, methane is basically from cattle and sheep. Yesterday only I was reading that New Zealand is doing very badly as far as greenhouse effect is concerned because they have got a lot of cattle and sheep and cows, farms, ranch over there. Hydrofluorocarbons, as we know, it comes from refrigerator and air conditioner. Nitrous oxide basically from fertilizers, and carbon dioxide from every type of burning, whether it is fossil or transportation or so. This shows annual greenhouse gas emission by sector. So almost all the sectors, they are contributing more or less equally. Surprisingly, India is faring well, and India is showing the ray of hopes to the world because in 2017, emission growth was 2.9%. That was half of the emission observed before 2015. This is due to emphasizing the use of clean energy by our government. Now we are living in a very unique times. When we were children, we used to look at the space, look at the sun, look at the moon. But now from the space, through satellite, we can visualize our own planet. That is why we can see that the tropical rainforests are shrinking, the intensification of agriculture, there is a loss of wetlands and expansion of urban centers. So new technology can measure changes in global photosynthesis, water cycle, and other major geophysical cycles. That is why we all know this. Now, why this global warming of late? Our even grandfather, grandmother, those who are living, they also say that situation was not that bad when they were children. But if you look at this slide, it is very interesting. Till 1800, the population of our planet was only 1 billion. But in next 130 years, it took to reach 2nd billion. Just imagine, only 130 years to reach 2nd billion. And in 2000, over the next 70 years, it tripled to 6 billion. And scary things are coming now. Between 2030 to 2050, they say that the population could be anywhere between 8 to 13 billion. And the alarming thing is it is developing, it is mostly in developing nations. So the first change is urbanization. 80%, 86% of the human lived in rural areas at the beginning of the 20th century. But now there are only 50%. Everyone wants to go to city and mega city. Same is the case with children. Their population in rural area have decreased. The another thing is industrialization after this discovery of whale since last 5 or 6 generations. Due to industrialization, obviously the energy production and use has increased. They are using more resources, so resources are extracted. Obviously, there is a crowding and pollution. They are utilizing more goods and services. Of course, they are specialized and they are doing production, giving employment to the people. But though it has shifted the focus from epidemiological focus from lower infant mortality and fewer infectious diseases to longer lifespans and chronic diseases of prosperity. The another thing is globalization. It has brought many advantages, but there are disadvantages also. The transportation is easy. Today you are here, tomorrow evening you could be at Copenhagen. There is global movement of goods and services. Trade has increased, and wide dissemination of information and communication is there. So technology. So the barriers are lost. The consequences of population pressure. There are no longer as many frontiers as it used to be. So humanity is distributed across the globe and extracting resources from land and sea rapidly. See, Coca-Cola, it's an American brand. It is in India. It is selling their cold drinks, but they are extracting resources from our own land. Now, Earth is a closed system. As we know, only sunlight, we derive energy from it. The rest of raw materials to provide food, shelter, goods and services, they are from Earth itself. So it's a closed system. Now that there are so many humans, as we had seen in population blast, they are using these raw materials. So they are making an unprecedented impact and the consequences are global. These impacts can be measured from the global to regional to individual to molecular level. Humans, they dominate planetary system. We have been blessed with higher functions, but simultaneously we are misusing it. We have transformed land by doing deforestation, desertification, urbanization. We have been overhunting and overfishing that practically threatens species by preventing normal replenishment of population. We have introduced invasive and exotic plants and animals brought from different parts of the world that may become pest or thrive because of lack of natural predators or competitors. We have totally changed, altered the course of nature. And all these trends often resulting in massive extinction. Like, for example, antibiotic and HIV resistant to drugs is going on. Plant and insect resistant to pesticides are going on. Rapid changes in invasive species. Life history change in commercial fisheries. Pest adaptation to biological engineering product. And of late, we have seen that our COVID virus also changing itself by altering genome structure and creating fresh challenges for the humankind. Impact of humans on global systems, as this chart shows, it is land transformation is 50%. Man has altered 50% of the land. Man has controlled or altered the two-third course of rivers. It has practically reached the optimum limit of hunting, and 50% of the nitrogen fixation is there. and some anthropogenic changes are irreversible. Mind well. Previously, 65 million years, till 65 million years, one species used to get extinct per year. Now that average has risen to 1,000 species per million. Just imagine 22 to 47% of the plants are endangered. And why this is important? Because plants are primary producers, the basis of the food web, and the only means by which sunlight is transformed into the organic building blocks of life. And these changes are irreversible. This is something to worry. Human affect the genetics of population. That is why just for us pediatricians, we know better that as pneumonia, it used to be, the resistance has increased from 3.8 to 44% in 1997. Now, the scale of change is tremendous. The countries most responsible for global environmental degradation, like US, they have benefited in the short term, but the harms will be felt most acutely in the poorest countries like developing nations that had less of a role in causing that same degradation. Similarly, generations in the future will be left to cope with the results of excess resource extraction, pollution, and degradation of ecosystems caused by those living now. Now, impact of global warming, we all reading, we all experiencing, but the problem with humankind is there. If we read about New Zealand, then we are relaxed that at least in India, we have such type of no problem like this. So nobody is thinking from a global point of view. There are killer heat waves, there are torrential rains and flooding, drought, forest and wildfires. Since last 10, 15 days, southern Turkey, near Antalya, the wildfire is so rampant that still it has not been controlled. And the resorts have been evacuated. Just imagine, it has reached the outskirts of Athens in Greece. So it has effects on health. There are indirect and direct effects. As we know, directly it causes loss of life, sunstroke, heat exhaustion. Heart patients are more at risk. There is increased ozone at ground level, which damages the lung tissues and leading to rise in asthma cases. Healthy persons, even they complain of chest pain, nausea, and pulmonary congestion, especially in bigger cities. If we remember, then Delhi regularly makes headline as far as pollution is concerned. Increased risk of infectious diseases. Then there are social environmental determinants, which all suffer. There is hardly clean air, there is hardly safe drinking water, the food might not be sufficient, and it may affect secure sheltering. The predicted mortality, the figures are chilling. Between 2030 to 2050, climate change is expected to cause approximately 2.50 lakhs additional deaths per year from malnutrition, malaria, diarrhea, heat stress. The effect on water resources would be tremendous. Land goes dry, lakes level will go deeper, the quality of water will be poorer, and overall there will be decrease in water quantity. Again, the data, it suggests very chilling picture for the future. If there is a diminished staple food in poorest region, it may increase the prevalence of malnutrition and undernutrition. So very few people know that the global warming will induce malnutrition. The effects on sea and coastal resources would be tremendous. Destructive erosion and wetland flooding, aquifer and agricultural soil contamination with salt, and there will be lost habitat for fish, birds, plants near coastal area. There will be dangerous hurricanes and typhoons and powerful storms. The impact on agriculture and food supply will be tremendous. There are indirect effects on health, like in agriculture field, there will be severe warming, floods, and drought may reduce yields. The livestock, they will be at risk directly from the heat stress and directly from the reduced quality of their food supply. And fisheries will be affected by changes in water temperature. Indirect effects on forests, like increased temperature, will lead to deforestation, and that is why decreased wildlife. United States Interagency Working Group on Climate Change and Health has identified at least 11 categories of climate change impact on human health. And they are direct as well as indirect, like increased air pollution related, increased injury, death, and illness from extreme weather events, increased waterborne diseases, increased foodborne diseases, increased vector-borne illnesses, increased heat-related illnesses, and diminished cold-related diseases. Asthma, respiratory allergies, and airway disease, as we know, it is due to increased human exposure to allergens due to altered and lengthy growing seasons. The growing seasons will be altered and it will be lengthy. The fossil fuel pollution will increase because of increased population and increased demand. Similarly, there will be increased particulate matter, nitrous oxide, sulfur dioxide, VOCs, and that will create diminished lung growth, increased respiratory infection, asthma attacks, increased infant mortality, and increased miscarriages, preterm and low birth weight babies. The air pollution related, it is so dangerous to children particularly. With climate change, we expect air pollution related illness to increase by at least 3 mechanisms. First, in hotter world, ground level ozone will increase, and children are more sensitive, as we know, to ground level because all the time they are playing near the ground. That is why even children without asthma will be affected. Second, in asthmatics, ozone triggers more frequent and more severe asthmatic attacks. And third, there is some evidence that ozone can contribute to developing new asthma in highly exposed children. There will be increased aeroallergens. Human allergic response to airborne plant pollens contributes to hay fever, allergic rhinitis, and allergic asthma, what we had seen in previous lecture. There will be increased aeroallergens and increased illness. There is a study from Canada. It showed a statistically significant increase in the length of the ragweed pollen season with rising temperature. The already existing allergens, they will be altered. For an example, poison ivy. Now it grows faster, it grows bigger, and there is increased photosynthesis. That is why increased use of water. The situation is alarming. As we know, cancer will increase due to increased ultraviolet radiation. Cardiovascular diseases and strokes will be there due to increasing heat stress. The foodborne diseases and nutrition, if we look at, there will be shortage of staple food. There will be malnutrition, even food contamination, like of seafood from chemical contaminants or biotoxin, and pathogenic microbes in crops by pesticides. The one study, 6-year study from Peru showed that there is an 8% increase in hospitalization for every degree of centigrade above the normal average temperature. So the foodborne infection will be due to higher ambient temperature, because during higher temperature, there is a different eating behavior. Like we have witnessed that in summer, people just simply go on drinking cold drinks and sugarcane juice and all these things. But there is a faster growth of foodborne pathogens. And similarly, global warming will produce more diarrheal illnesses. There will be heat-related morbidity and mortality. Like increasing temperature causes prolonged heat exposure, leading to increase in incidences of heat exhaustion, heat cramps, heat strokes. There will be thermal extremes, heat-related deaths, and who will be vulnerable population? Elderly, debilitated, very young, urban dwellers, economically disadvantaged. So developing nations will suffer a lot. Human developmental effects will be there because of decreased food supplies and exposure to toxic contaminants and biotoxins resulting from extreme weather events. Mental health and stress related disorders, everybody has seen in this COVID pandemic. So it is going to increase because of damage to property, migration of the population, loss of loved ones, and chronic stress, all of which can negatively affect mental health. There will be increase in vector-borne and zoonotic diseases. We have seen that malaria is the same problem it used to be in 1960, because it shortens the pathogen incubation period and disruption and relocation of large human population. There will be more vector-borne illnesses due to enhanced infection prevalence, prolonged transmission seasons, and extended range. We all know how pathetic situation as far as malaria is concerned even today. There has been increase in Lyme disease in USA, leading to mosquito-borne encephalitis, tick-borne encephalitis. Waterborne diseases will increase because of increase in water temperature, precipitation frequency and severity, evaporation, transpiration rate, and changes in coastal ecosystem. It could result in incidents of water contamination with harmful pathogens and chemicals. There will be weather-related morbidity and mortality directly, like what we are reading nowadays in Greece and Turkey, the direct effect of hurricanes, floods, droughts, and wildfires. The neurological diseases and disorders are going to increase. Now, this is very interesting slide. The Wildlife Conservation Society has identified 12 pathogens could spread into new regions as called deadly dozen. If we look at carefully this slide, there's avian flu, tuberculosis, Ebola, cholera. There is no COVID virus here. So just be prepared for future shock. The impact of climate change on health is tremendous, as shown in this graph. Now, what we can do, mitigation strategies. Switching to low carbon energy sources like renewable and nuclear energy, expanding forest and sinks to remove greater amount of carbon dioxide, adapt to global warming are actions taken to manage eventual impact by building dikes in response to like sea level and become energy sufficient. At times, economic consideration has to be emphasized while selecting an alternate source of energy. In 2015, there was a Paris Agreement where it was decided that long-term goal is to keep the increase in global temperature to well below 2 degrees Celsius above pre-industrial level. So this is the minimum goal. But alarmingly, even now, the temperature are more than 2, 3 degrees, even 4 degrees in some of the countries. 45% average per capita carbon footprint is individual activity. So it is under personal control. But it is much higher individual footprints in most industrialization and much lower in developing nations. Then mitigation in developed countries, contraction and transition to low or no carbon energy, while in developing countries, there should be climate proofing with clean energy and sustainable development. And it is very heartening that our Prime Minister is really doing good work in this direction. There are mitigation strategies. Personal choices matter. You calculate your carbon footprint, reduce it, and tell the stories to your children. Practices choice matter. Green your office and institution, educate and innovate. There are political choices. Make change locally, educate decision makers, go to your municipality president and convey to him. Participate fully in the local political process if needed. Like find the win-win choices, like for an example in USA, burn calories instead of carbon. More active transport cleans the air and fights obesity because muscle power is carbon neutral. Social time instead of screen time, more interactive family and group time combats isolation and even depression. And eat fresh, local and lower on the food chain because it supports the local farms, economy, improved nutritional quality, lower risk of chronic diseases. And energy efficiency saves the money, like wealth supports the health. Find win-win choices, like for an example, India. Replace biomass with clean renewable energy and develop smart local electrical grids because it reduces emissions and prevents new emissions, prevents cardiopulmonary diseases and death, and gets necessary energy to household. You improve public transport, create more bike lanes. You promote solar, hot water and water conservation because it reduces air pollution, it promotes health, it saves money. You strengthen traditional diet, continue to eat low on the food chain. The triple bottom line is sustainable community, that is planet, strong economy, that is profit, and health of the people. Alternative energy like from wind, wave, solar, it is carbon neutral, it creates new green job and clean air. There should be green buses, more bikes because it reduces cars and emissions. Now, 2 or 3 slides, what you can do. Suppose if you replace your old refrigerator with a new Energy Star, then annual savings would be 315 kg of carbon dioxide. You just drive 15 few kilometers per week, then you save 234 kgs of carbon dioxide. You just replace just one incandescent light bulb with one CFL. You reduce 67.5 kgs of carbon dioxide. You reduce your garbage by 10% through greater recycling or reduced packaging. Then you save 540 kg of carbon dioxide. We hold our future in hands. Thank you very much. Jai IIP, Jai Hind. I again thank IIP Kerala branch for giving me this opportunity. Thank you.
Thank you very much, sir, for an excellent and elaborative talk. Since lack of time, we'll have a discussion later. And let us go to a next topic. And good morning all, and all my seniors and my dear friends. First of all, I thank Environment and Child Health Group IAP Kerala and IAP Pathanamthitta for inviting me for chairing this session. As you all know, we are facing a major problem of global warming and climate change along with the COVID-19. We all know that in April and May, because of the lockdown, the pollution is decreased a lot and biodiversity has started coming back. In a nutshell, for any misfortune, definitely some good thing will happen. To talk on this, we got an eminent speaker, Dr. Vinod Radagiri. He's a professor of KIMS Habali, Karnataka Medical College, and he got more than 50 publications. He got an award of Satyagupta Award in 1999 for his best paper, and he held a responsibility of different positions in IAP Karnataka. Welcome you, sir, for the next talk. Thank you. Vinod, sir.
Yeah.
I've just made sir into a co-host. Sir might not have been able to unmute.
Now
himself.
able to hear?
Yes, sir. You are able to. You're audible, sir.
Is
Go
my,
ahead, sir.
yeah. Is my screen visible? No, no problem.
Yes, sir. Yes,
Okay.
Sir.
Okay. Thank you, Dr. Zailam, for giving me such a wonderful introduction. And I take this opportunity to thank the IIP Kerala State Branch, both the Allergy and Environmental Chapter for giving this opportunity. And again, thank our seniors of Environmental Chapter, Dr. Sukumaran sir and Paramesh sir. Now, as we are all into this COVID pandemic, we all know every day we are hearing about this one. And this pandemic has affected every part of human life, including the physical world. And if you see the dashboard of WHO, say more than 20 crore people are infected with this virus and more than 200 countries are affected. And if you see the top 3 countries, and India stands in the second list. So much is the effect of this COVID-19 on our life. Now, it's not moving. Okay. So COVID-19 has not only created a health crisis, but slowly it has also evolved into an impact on both economy as well as the other social aspect also. Now, taking into consideration now the priority for all of us, including all the government across the globe, that public health is the most important, and that's what they are now taking. And first of all, you see the environment, which has been already neglected with this pandemic and giving priority for this, it has again caused an enormous impact on the environment. So this has been already neglected and much more neglected by this COVID-19. So environmental health problems have received less and less attention from various aspects, including the government agency, the scientific community, and the general public in health. Now, if you see this one, the recent one, if you see the net, if you put a just word COVID-19, you see n number of publications. But if you see, look at that one in relation to COVID-19 and environment, the number of publication has less than 3% only. So that is, say, around 20,000. Most of these publications are related to medicine and health, almost more than 65%. And if you see, even in the environment, the most papers are related to other than what is to be addressed. Say, we are seeing more number of negative impact, which I'm going to deliberate in next slides. That is plastic pollution, which is the major hazard we are seeing as a negative impact of this COVID-19, not much stressed in these papers. So in other words, I wanted to just highlight that still, though the problems are due to environment, due not handling properly environment, that is led up to these pandemics, but still the government, the public, and the scientific community is not giving much attention for the proper care of this environment. Now, in my next 15 to 17 minutes, I just want to highlight about the natural ecosystem. If it is being disrupted, how it is going to produce various impact on human beings. And we all know there are many pollutants in the world now increased because of anthropogenic activities. What is their relation in terms of incidence and spread of COVID-19? And then I'm going to highlight about the indirect impact of COVID-19 on environment, which is my major area. I'm going to cover both the positive and negative aspect of this impact, and then how we can maintain the whatever advantages we have gone through this COVID-19 impact on human beings, and what are the negative impacts which are created, how we can prevent that one in future and maintain the environmental sustainability. Now, we all know that this pandemic has brought profound social, political, and economic and environmental changes to the world. The virus may have emerged from wildlife reservoirs, which we have all seen and heard that this has come from the Wuhan city of China. And this has mainly because of environmental disruption. And it was transmitted to humans via the wildlife trade, again, and human activity. And then it spread all over the world by this economic globalization. So this pandemic has arrived importantly. Say, we are already facing a lot of environmental threats, environmental problems, including wildfires, high temperature, floods, and storms. And to this now added is this pandemic. So all in all, because of environmental problems, we are facing all over the world the health hazards. To overcome these challenges of this COVID-19, we need to address all these aspects like social, economic, and including the climate change. Then only we will be able to overcome this problem. It is not a single entity, it is a combined entity by which we will be able to overcome this crisis. Now, in the past, we have seen many pandemics, but compared to that pandemic, COVID-19 is slightly different. Still, we are seeing there are uncertainty in management, and there are a lot of debates going on in managing these cases, unlike the earlier pandemics, if you see that one. However, all the evidences so far for all these pandemics indicate that these are not a random diseases, but a consequence of inappropriate interaction between humans and wild animals. So a global sustainable development approach is highly needed to address these global variations, which must be considered in all sectors simultaneously in order to understand the interaction between the environment, the disease, and the human activities, so that we'll be able to overcome the problem. The relationship between environment and COVID-19, the various factors which have caused virulence of this disease, mainly the respiratory system, what we are seeing is a major problem, is because now the environmentalists have specifying that it is because of pollutants, which is exaggerating these COVID-19 problems in many of these patients. So we need to recognize this pandemic. Basically, it is a human tragedy and it is being created by us only. So we need to tackle this one by doing proper work. Now, why it has happened? What is that natural system, natural ecosystem, which was there, which was disrupted by our human activities? So the management of natural resources has an impact on quality of our life. The current economic system, which is having a strong focus on unsustainable exploitation of natural resources, including our lifestyles, framing the megacities without much proper basic infrastructure, which has led to congregation of people and which will lead to the spread of these diseases very rapidly. And all these modified natural environment is creating a source for these pandemics. Natural ecosystem not only provide economically valuable resources, but it also provides the human well-being. That point we need to know. If we have inadequate environmental management, that will reduces the benefit of our economic ecosystem services, and it will threaten us with various pandemics, what we are seeing now. So it is important that we don't want to lose these natural habitats. In turn, if you lose, there will be an interaction between wildlife, domestic animals, and humans, which is the source for spreading most of these pandemics, especially these viral disorders. It has been established that scientifically that if there is an interaction between humans and animals, there is a great chance of the pandemics in future also. So we need to tackle this by doing appropriate action on the environment. Now, coming into the other part of this one, it has been, as I have told, that most of the problems are now seen is because of pollutants. And it is being seen that these relationship of environmental factors and various pollutants has already been established. The pollutants and the viruses produce, more importantly, negative immunological responses, which are having a similar basic mechanism in producing the disease. That means pollution, or especially particulate matter, now it is being established that it can sometimes carry even viruses also, or it itself can produce a mechanism, a disease, which mimic like a viral disorders. So all these can lead to increase in diseases. So we all seen that there is a, because of anthropogenic activity, there is an increased particulate matter, specifically 2.5 and 10, which has in turn increases such pandemics if there is a increased pollution across the world. But still, there are points which we would like to know that all the factors, whatever now come into the literature, may not be correct. So we need a lot of still work to find out what other risk factors, what other environmental factors can increase the risk of spread of these pandemics. The only thing I would like to highlight is we can tackle these problems by doing or by taking care by that one word called One Health. That is between approaching ourselves as physicians, veterinarians, and use of these biodegradable medical supplies. If it is being combined, work together, then we will be able to overcome these crises. So this is what is being seen now as an effect of pandemic. So we are seeing because of this disease, the human beings now are to go for this hand washing using soap and water and various sanitizers, which itself, if it is being used in large, can produce some environmental impact. Then mass disinfection, though it is mainly for protecting the people, but again, it has its own environmental impact. And more importantly, the PPE, want to protect ourselves and our people, has again increased the plastic pollution. There are some good effects which I'm going to highlight in future slides, like air pollution, which has been improved because of slowdown in economic activities because of lockdown. We have improved air pollution, but in turn, the lockdown has also produced, there are various economic problems also. And other problems, the negative impacts, I'm going to highlight in the next slides. The point I was just wanted to highlight again here as an environmental part, that it is being established that these pollutants, specifically the various persistent organic pollutants and other things, which have been increased in the past decade because of anthropogenic activities, mainly because of the industrialization, because of increased motor usage, that has produced various pollutants into the air, and that has caused main respiratory problem. And during this pandemic, the virus which is affecting again the respiratory system, both has added effect and worsened the problem. So it has been found that pollutants are going to change the immunological profile in the human beings, and it is being established. It will affect the T cell receptors, growth factors, cytokine receptors, and B cell receptor. In turn, it mimics like a viral diseases. So if there is an added problem like air pollution and there is a COVID infection, there is a high chance of increase or severe diseases in these children. It is very been well established. But for others, still a lot of research is needed to find out the relation between other environmental factors. In a study in USA, they have noticed that they have conducted this study using various factors. They have taken 20 factors, and they found that there is a strong relationship between particulate matter and death risk from the COVID-19. So it is not only in US, in various other countries, including European countries, China, and even Southeast Asian countries, it is proven beyond doubt that these particulate matter, if there is an increase, then there is an increased chance of severe disease in COVID-19. But again, as I told, there are concerns about other risk factors and their relation, specifically in indoor pollution. Indoor air pollution, specifically more common in Southeast Asia as cooking material. Still, it has been other usage. That's the reason it is not been still well established, but there is again concern that there might be an increased chance of increased severity of COVID-19 wherever there is an increased indoor air pollution. But this has to be still rectified by various studies. So these are the various studies which is being shown that air pollution increases the chance of severity of COVID-19. Now, regarding transmission of the SARS-CoV-2 and the various environmental factor, it is still under the process. Many publications have come out with various environmental factors, but the cause and effect relation still need to be analyzed properly before we conclude that these are the most important risk factors for increasing the spread of these COVID-19. So these various environmental factors has been studied, including temperature, humidity, and wind, and they have a mixed results in these. So we need to still have time to find out the real impact of these environmental factors on spread of COVID-19. Now coming to the major impact which we have seen, which we have categorized as the positive impact of environment and negative impact of environment because of COVID-19. We have a positive impact. It is mainly short-term impact, and it is because of lockdown. This is in the form of the better air quality, better noise, reduction in the noise pollution because of decrease in the greenhouse gases. And overall, there is a improved air quality in this. And more importantly, we have seen in recent times that many of these other ecosystem animals have come to their natural places, and it is being seen in various pictures. But what we are now seeing is the long-term impact. Mainly it is negative, which we need to concentrate. It is mainly because we have prioritized for saving the lives. In turn, we have produced now, because we are using masks, we are using PPE, which is again a plastic component, which is not being recycled, and which again increase the medical waste. And that is causing a lot of impact on the environment, and which in turn, it will again damage the human life. So this is another picture which I tried to say which are the positive impacts and which are the negative impacts. The negative impacts is mainly because of plastic pollution used by mask and personal protection, and also the sanitizers and mass disinfection in various areas can also cause a lot of environmental disruption. The positive impacts we have seen in recent times is mainly because of lockdown in the form of air pollution improved, noise pollution is improved, and other, to some extent, water pollution is also improved. Now, these are the studies where it is being proved beyond doubt that in India, Delhi, when they have taken during lockdown period, these particles definitely has decreased. Particulate matter 2.5, 10, and NO2. NO2 is representing the global economic activity, because it is mainly from the motor activity and industrialization. So if there is a decrease in NO2, definitely it indicates that there is a slowdown in activities, economic activity, especially industrial and motor vehicles. And it is being seen that if there is an increased NO2, it is being noticed that there is an acid rain and so many other problems we are seeing. Now that has come down during this lockdown. Similarly, SO2 is also decreased during this lockdown time. And it's again an Ahmedabad study which has been shown that there is a lot of decrease in NO2 and other particulate matter during lockdown. And this is the picture showing that because of a lockdown, there are a decrease in the activities, mainly the energy producing. We are getting most of the electric energy by using coal. Coal in turn causes a lot of environmental hazard. Now, because of lockdown, this industry has come down and it has reduced during lockdown period. So the air quality has improved. It is not only in India, in various other parts of the world also, it has been seen. And again, carbon dioxide, see this picture, again, there is a reduction during the lockdown period. This is the satellite picture showing during lockdown, there is a decrease in the NO2 levels. And again, one more, compared to previous 4-5 years, there is a lot of pollution in India. And during lockdown period, there is a drastic improvement in the air quality. So overall, this COVID-19 has impacted. There is a decrease in the particulate matter, decrease in NO2, and decrease in noise pollution. And to some extent, there is an improvement in the water pollution. But what is being impacted is the plastic pollution. And if you see this picture, again, improvement because of lockdown. So, and see these pictures. So more importantly, noise pollution, Delhi study has shown that because of less vehicles, the noise pollution are reduced to less than 40 to 50 decibel. And this 40 to 50 decibels is reason why we are able to see the chirping sounds of these birds and others in the cities during the lockdown period. Now, the most important negative impact what we see because of COVID-19 is the plastic pollution. So this has a major impact what we are seeing. So that we have to take into consideration. So this has made our life more problematic because we ourselves need to protect by using mask and the PPE. So this has increased the medical waste, and we have a idea to decrease this one by proper dissemination of this medical waste. Mainly now, earlier it was incineration and landfilling was there. Because of increased this thing, there is a haphazard and there is an increased chance of environmental pollution if you are not properly incinerating and landfilling these medical waste, which has been happening in the most of the municipal cities because of increased medical waste. Now, another bad impact what we see, it is again humans. If they are not properly disposing these masks, they will end up with this one. This is a person in the Bangla beach. It has been noticed around the sea that so many masks are there on the beach sides. So plastic indeed offers a good quality of our life. It is must, but if it is being in excess, again, it can produce a lot of problem to the human life. So what is the best way to avoid this plastic? Plastic is needed, but what type of plastic? It is bio-based plastic, which is required at this hour so that the recycling process will be better and we can have these equipments without the cost on environment. So lastly, I just wanted to cover how we can overcome these problems. How can we maintain these strategies so that whatever positive we have achieved during lockdown and whatever negative we have, how to overcome these problems. So before I move on to those 8 sutras, how we can sustain the environmental factors, I just wanted to highlight that the United Nations has given sustainable developmental goals, which are around 17. In that, because of this COVID-19, there is some improvement in the goals, specifically the pollution related, like air quality has improved. So 11, 12, and 13 has improved. But rest of the sustainable goals have been worst affected. So these are the 17, this thing, except those 3 remaining, all are affected. This is the picture I have but I just wanted to highlight the poverty has increased because of lockdown, hunger has increased, and well-being of that one is being increased. These are all the impact of the COVID-19 on human health. These are the 8 sutras we need to follow, mainly these sustainable industries, use of green and public transport, use of renewable energy, wastewater treatment, waste recycling, ecology restoration, and behavioral changes what we need. And lastly, all our cooperation, including all others in the world. That is what is needed. So sustainable industry, just quickly, it is mainly renewable energy, what Dr. Ramesh Bajani has highlighted, we need to go for, and use public transport for reducing the carbon footprint. And as Dr. Ramesh Bajani has said, that we have to go for other resources, renewable energy, use wind, solar, and other things for producing electricity and not the coal, which is worsening the environmental problems. Wastewater treatment, again, before you put it into a river, and that can reduce the water pollution. The waste recycling, again, an important one. And then ecological restoration is most important one. This is very important because we have seen now the tourist places many people are visiting, and which in turn produces a lot of carbon footprint. So the idea is here, intermittently, if we stop these parks and other things, visiting places, we'll be able to restore the ecology. That is what is being there. And then importantly, it is behavioral change of our life that can improve the environmental pollution. So this has been already highlighted by Dr. Ramesh Bajania. Lastly, there is a need for international cooperation to reduce the plastic pollution and other air-related pollution problems. So to conclude, there is unsustainable environmental management, which has contributed to there is an increase in zoonotic diseases, including this pandemic. And pollutants has been the most important association with COVID-19 in terms of severity because of immune alteration. There are both positive and negative impacts of this COVID-19 on environment, but negative impacts is causing long-term process. Only way we can achieve sustainable goals by using One Health approach, wherein all of us together bring down all environmental pollutions. So, friends, though the impact of COVID-19 on environment are short-term, there is a positive benefit, but united, all of us, and proposed a time-oriented effort can strengthen our environmental sustainability and save the earth from the effects of global climate change. Before I can, one word saying, so one word is nature. For nature, humans are not needed, but for us, nature is needed. So it's our duty, all of us, that we have to take care of environment so that environment in turn can help us to protect our health. So I conclude this by having a smile that we are shortly overcome this pandemic. Thank you one and all. I again thank the Kerala State Branch for giving me this opportunity to talk on this impact of COVID-19 and environment. Thank you.
Thank you very much, sir, for the excellent talk and detailed explanation. And the main message which we could feel is the most important thing. One thing is recycling, second is restoring, and behavioral changes are required for the day. Anyway, because of the want of time, we can go to the next. You can answer the questions in the chat box.
Sure, sir. Sure.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, Vinod sir and Ramesh sir. Now we would like to thank Bennett sir and Harikumar sir for the excellent moderation. Now we are moving on to the next session. For the moderation of the same, we have our own two academic giants, the C. Jayakumar sir and Anandakeshavan sir. For the first speaker, we have my own good friend, Dr. Vikram Patra. I would like to invite Jayakumar.
Unmute.
I'll be unmuting Jayakumar sir in just a minute.
Hey, good morning.
Jayakumar sir, you can unmute yourself, sir. Good morning, Anandakeshavan sir.
Yeah.
Okay. Hello. Am I audible?
Yes, sir.
Okay. Respected President of IAP Kerala, Dr. Jairam, Secretary Dr. Johnny, National President-elect Dr. Ramesh Kumar, President of National Allergy Chapter and past President of IAP Dr. G. Sukumaran sir, Dr. Jose, National Secretary Dr. Balajandar, Dr. Jijo, Dr. Harikumar, CB, Naushid, and the senior most pediatrician Dr. Roy Alexander and the excellent organizing team. So you know that today we are going to hear from Dr. Vikram Patra about anaphylaxis. Anaphylaxis is a condition that nobody can afford. Pediatrician cannot afford, physician cannot afford, and even the patients cannot afford. And my point is that diagnosis and management of anaphylaxis should go beyond medical schools. So it's not a bad idea if we conduct a survey about children and adults with a history of anaphylaxis and form a registry so that we can educate them, we can teach them. And that is the need of the hour in this anaphylaxis. To talk about this, we have an excellent speaker, Dr. Vikram Patra. He's the Associate Professor of Pediatrics in MGM Medical College, Navi Mumbai, and he's in charge of the Allergy and Immunology chapter, and he's a trainer of under 5 years. So with these words, I would like to invite Dr. Vikram Patra to deliver his talk on acute anaphylaxis. Dr. Vikram Patra, please.
Yeah, good morning all. Thank you, sir, for your kind words. And at the outset, let me thank IAP Kerala, the Allergy and Immunology chapter, and the Environment and the Child Health Group for giving me this opportunity to talk. And I extend my thanks to Dr. Ramesh Kumar sir, Dr. Sukumaran sir, Dr. Jose sir, my friend Dr. Jijo for this opportunity. So my slides are visible to all?
Yeah. Start sharing. Start the sharing. Okay. 1 second. Still moving. Okay. It's okay now.
Yeah. So in next 20 minutes, I'm going to brief on this important topic of acute anaphylaxis. So let me, at the beginning, dedicate my talk to my teacher and my mentor, late Professor Major K. Nagaraju sir. Sir will be forever indebted to you for your role in pioneering pediatric allergy branch and taking it to such heights. So to start with, as sir mentioned, who should know about anaphylaxis? Is it the allergist or pediatrician and physicians, nursing staff, healthcare workers, parents, or school teachers and caregivers, or restaurant owners or staff? The answer is everyone. The knowledge to handle, recognize, and to give first aid should be delivered at community level, as sir mentioned. So what is anaphylaxis? Anaphylaxis terminology is coined as against prophylaxis. It comes from Greek word phylaxis, means protection, and ana means backward protection. So though the incidence of anaphylaxis is very small as compared to other allergic disorders, but it lies on the severe form of the spectrum. So is there any definition? Yes, various organizations have come out with various definitions in 2011, 13, 10, 16, 2006. But recently WHO in its 11th edition has come out with the definition, and which mentions as anaphylaxis is a severe, life-threatening, systemic hypersensitivity reaction characterized by being rapid in onset with potentially life-threatening airway, breathing, or circulatory problems, and is usually, although not always, associated with skin and mucosal changes. So long back in 2005, until now, these criteria were used, which were given by National Institute of Allergy and Infectious Disease and Food Allergy and Anaphylaxis Network. Any one out of these three was sufficient for diagnosing anaphylaxis. The first criteria was sudden onset of an illness, which occurs within minutes to several hours with involvement of skin and mucosal tissue in the form of generalized hives, itching or flushing, and swollen lips, tongue or uvula, with at least one of the following systemic features like sudden respiratory symptoms and signs in the form of stridor, wheezing, sudden onset cough, hypoxemia, and or sudden reduced blood pressure or symptoms and signs of end organ dysfunction. Second criteria, in presence of, now the first criteria, no exposure to allergen is required. If those are there, you directly treat it as anaphylaxis. The second criteria, if there is exposure to a likely allergen or other trigger, so then two or more of the following, which occurs within minutes to several hours, they are sudden skin changes, respiratory compromise, sudden reduced blood pressure or symptoms of end organ dysfunction. And in the second criteria, they have included gastrointestinal symptoms also in the form of crampy abdominal pain, vomiting. And third criteria, if a known allergen is there for that patient, and if they present only with hypotension, reduced blood pressure, then you label them as anaphylaxis, even if there is no skin or respiratory presence. And for infants and children, we know, so low systolic blood pressure is aspecific or greater than 30% decrease in the baseline systolic blood pressure. And in adults, anything less than 90 millimeter of mercury or greater than 30% decrease from the person's baseline. But but following those criteria, many anaphylaxis were not fitting in the definition. So to avoid the confusion, World Allergy Organization recently in 2020 came out with a simplified version. And what it did, it combined the first two criteria and modified the third one. So in the first criteria, they included the gastrointestinal symptoms along with the breathing and circulatory problems in addition to the skin involvement. And in the second criteria, in presence of probable allergen or a known allergen, either of these three, like skin involvement is not required, but hypotension as it was there in the third criteria in the NIAID. But along with that, even if there is bronchospasm or laryngeal involvement, they are also to be included. So many cases were like that, they present with only stridor after consuming. So they were not getting fitted in the anaphylaxis definition. So after knowing all these things, let us go through a case of Master M. He's a 3-year-old male child who developed sudden itching of skin with rashes followed by acute onset stridor and breathlessness. He was rushed to emergency room. He was hypotensive. He was diagnosed and managed well as anaphylaxis. And he was fitting well into the first criteria. So what further questions to be asked? To know the trigger, on inquiry, he had consumed prawns. Never he had such reaction in the past, and never he had reaction to fish. And there was a strong family history of atopy in the family. Mother had severe allergic rhinitis. So what are the triggers then? So as Narayan Prasad Modi sir very well said, food allergies are very common in children. So foods are the most common anaphylaxis triggers even in infants, children, adolescents, and young adults. And these are the 8 common food allergies which we found. And most common among them is milk, followed by wheat, egg, peanut, tree nut, soya, fish, and shellfish. But in adults, the most common triggers are drugs and insect stings. Food allergy is rare. And we as pediatricians, we must know, though rare, even vaccinations, they carry the risk of anaphylaxis. And these are the potential allergens which are present. So commonly allergens in influenza vaccine are the egg proteins. And gelatin is the most probably cause of most severe allergic reactions to MMR. And other components like antibiotics like neomycin, thiomersal, aluminum salts, latex, they rarely contribute to the anaphylaxis. So we need to know these things also. So after say everything, so the mast cells are the plays the key role or the key player in the orchestra of anaphylaxis. So once activated, they go under degranulation and to release histamine and other mediators, which brings about these symptoms and signs of anaphylaxis. So how they get activated? So they can, depending on the mechanism, the anaphylaxis is classified as Ig mediated and non-Ig mediated. So Ig mediated are the classical ones where they act through the IgE and Ig receptors. But whereas non-Ig mediated further classified into immunologic and non-immunologic, wherein immunologic, they are IgE independent. They are mediated by IgG, complement system, and contact and coagulation system. Non-immunologic, they bring about changes by direct activation of mast cells. And recently, a third type has been introduced, the idiopathic. As mentioned, IgE is the most classical and the most common thing. IgE mediated is seen for various food, medications, radio contrast media, bee stings, occupational allergens, aero allergens, and rarely rubber latex. Whereas non-IgE immunologic mechanisms, IgE independent, radio contrast media, paracetamol and other NSAIDs, dextrans, certain biologic agents, they cause anaphylaxis through this mechanism. And non-immunologic mechanism by direct mast cell activation are physical factors like exercise, emotional stress, cold, heat, sunlight, consumption of alcohol, and certain medications like opioids. Opioids, they cause direct mast cell activation. And idiopathic anaphylaxis is where no apparent trigger is known. So it is assumed that they may have some underlying mast cell disorder like mastocytosis, and recently diagnosed meat proteins which were previously unrecognized like alpha-gal. Now there are certain factors which increases the severity. They are endogenous to the patient and sometimes exogenous. So endogenous, gender. So below 15 years of age, males, they are more prone for anaphylaxis, and above 15 years, females percentage increases. Whereas age, more fatal anaphylaxis are seen in elder groups rather than pediatric group. If they have certain underlying diseases like cardiovascular disease, mastocytosis, atopic disease, certain ongoing infections, and exogenous medications, as we discussed, physical activity, psychological burden, sleep deprivation, all these, what they do, they bring down the threshold for allergy and anaphylaxis. So these are the concomitant diseases like atopy, as I mentioned, allergic rhinitis and eczema, having baseline asthma. So if a child has got asthma, there are more chances if they have food allergy, then landing into anaphylaxis is more common in such a patient group. Certain psychiatric illnesses like depression, symptoms of anaphylaxis may be masked. Now, there are certain cofactors which amplify the anaphylaxis. They are having concurrent medications like alcohol or recreational drugs, and drugs like beta blockers, AC inhibitors, and NSAIDs. They all amplify the severity of anaphylaxis. And the physical factors like exercise, acute infection, emotional stress, perimenstrual status, that's why more than 15 years old females are more commonly affected. So coming to finally management, how Master M was managed. So first of all, we need to know what is the drug of choice, which is the first line of drug, which is the life-saving drug, and which is the safest drug, even if you are in doubt whether the diagnosis is anaphylaxis or no. The answer for all these questions is adrenaline, adrenaline, and adrenaline, which is also called as epinephrine. So why not which injection Avil, hydrocodone, which were rampantly used? Why only adrenaline? It is clear from this thing, in anaphylaxis, the systemic involvement leads to more severe cases like cardiovascular, respiratory, GI, and those skin and behavioral involvement are there. And if you look at this, adrenaline works better. Adrenaline is effective for all symptoms, but better works in the systemic involvement, whereas antihistamine is better for skin and behavioral problems which are not life-threatening. Secondly, when given intramuscular, adrenaline onset of action is within 5 to 10 minutes. And adrenaline reduces air mucosal edema, induce bronchodilation, induce vasoconstriction, and increase the strength of cardiac contraction. So adrenaline is the preferred medication. At what dose we recommend? The dose is 0.01 milligram per kg of body weight. That is equivalent to 0.01 ml per kg of 1:1000 adrenaline, which we get in the market, and to a maximum dose of 0.5. And for a rough calculation, 1 to 5 years age, it is 0.15, 6 years to 12 years, 0.3 milligram, and teenagers and adults, the dose will be same as adult, that is 0.5 milligram. And for infants whose weight is less than 10 kg, then we should calculate in terms of body weight. Now the flow chart, when we get a case of anaphylaxis, the initial assessment should be same, A, B, C, D, E, airway, breathing, circulation, disability. Monitoring should be started. We should activate the emergency team, and simultaneously adrenaline should be injected. If it is in a hospital setup, then pulse oximetry, ECG, blood pressure monitoring, IV fluid should be started, airway is established, and high flow oxygen is started. Positioning, as I mentioned, is very important because fatality can occur within minutes if a patient stands, walks, or sits suddenly. Patient must not walk or stand even if they appear to have recovered. And do not allow the patient to stand or walk until they are hemodynamically stable, and which we expect a minimum of 1 hour after first dose of adrenaline, and 4 hours if the patient required more than 1 doses of adrenaline. And these are the recommended positions. The preferred position is the lying down position with lower end elevation. if a person has got respiratory problems like stridor or wheeze, he can be allowed to sit in a propped up position, but the person should not stand in a sitting position with legs fold. The legs should be extended. He should never stand. In case of unconsciousness or vomiting, or in case of pregnancy, left lateral position is advised. In case of infants, the child should be held in an horizontal position and not in a vertical position. And this is an overcrowded slide, but very important one. So after initial evaluation, we should keep our threshold for the diagnosis of anaphylaxis very low and consider lower threshold by, and thus adrenaline should be given if there is history of previous severe reaction, we know certain allergy, and if there is coexistent asthma. If possible, if the anaphylaxis is due to some drug or some topical application, they should be removed. And we should look for, after giving adrenaline injection, we should look for other involvement like hypotension is there or no, respiratory compromise in the form of stridor or wheeze is there or no, and then accordingly we should treat with sodium normal saline bolus for hypotension, nebulize adrenaline 5 ml of adrenaline for nebulization in case of stridor, nebulization with salbutamol in case of wheeze, and if still within 5 to 10 minutes if there is no improvement, we should repeat IM adrenaline, and meanwhile we should access for the IV and patient should be shifted to ICU. And if further there is no improvement, we shift to other vasopressors and ICU care treatment is started. So on simplifying, first statement it is, if in doubt, give adrenaline, IM, 0.01 ml per kg, that is 0.01 mg per kg of 1:1000 solution. So while giving adrenaline, we should take care of the respiratory and circulatory problems in this. And we can repeat at 5 to 10 minutes interval if there is no improvement. We can repeat 2 to 3 times IM adrenaline. And if still not responding, shift to ICU and start IV infusion with adrenaline. Again, while transferring, the child should not the patient should not walk or sit. He should be, a trolley should be used. And in PICU, we should start IV infusion with adrenaline to start with 0.1 microgram per kg per minute and can be raised to 2 microgram per kg per minute. If persistent hypotension is there, then further NS bolus are given and IV infusion or adrenaline is started under strict blood pressure monitoring. And in case of beta blocker consumption, if a person or the child or the patient is on beta blocker, they may be refractory to adrenaline, so glucagon works better. But rarely we encounter these kind of cases. Most of them respond to adrenaline very well. And if they have present, if in a case of known asthma, if they are presented with wheezing and they have certain allergy to food, we should not jump to nebulization first. We have to give adrenaline first and then asthma relievers should be started. Now, what about diagnosis? Is it important to diagnose? Diagnosis is purely clinical, but if you want to document, then serum tryptase rather than serum histamine is the preferred one. Why serum tryptase? Because it's longer. Histamine half-life is short, disappears within 1 hour of onset of the symptoms, whereas serum tryptase, the peak is achieved between 0.5 to 1.5 hours. So ideal situation, it should be collected after 1 hour after the resuscitation. So tryptase are useful in the follow-up of suspected anaphylaxis rather than initial recognition and treatments. Measuring tryptase must not delay initial resuscitation. This is to be clarified that diagnosis should not be made at the, we should start treatment and then after 1 hour of settlement, we can go for tryptase level. And rather than single samples, serial samples have better specificity and sensitivity than a single measurement in confirmation of anaphylaxis. The first sample is collected when IV line is secure. Second, within 1 to 2 hours. And third, after 24 hours or follow for baseline tryptase level to rule out underlying mastocytosis. If single sample is used, then the preferred timing will be 1 to 2 hours. Now coming back to our case, Master M. After 6 months, family went to a restaurant for a get-together. He consumed fish only there, but immediately he developed similar episode and was hospitalized. So what could be the reason here? Parents were panicked. Whether now the child got sensitized to fish even? On inquiry at restaurant, the same utensil was used to cook fish and prawns. So maybe it was the contamination. Later on, after 4 weeks, the child underwent skin prick test and he was diagnosed to have sensitization to prawns and dust mite, whereas fish was negative. Parents were happy that the child at least can have fish. And component result diagnosis was advised to look for cross reactivity between prawns and dust mite. So in that case, if the child is provided with the immunotherapy with house dust mite, the child can start having prawns also. During the second episode, he got settled within 2 hours, as in first episode. So, but they were not convinced for hospitalization, went home. The same day, during midnight, he started feeling similar episode. Parents were taught to administer injection adrenaline, and this is very important. Parents and patients should be taught. And they gave the adrenaline and brought him for hospitalization. So what is this condition now? So this is what is called as biphasic reaction. These are the anaphylactic reactions which have been reported in up to 20% of reactions. They usually occur within 4 to 12 hours of the first symptoms or signs, and they may be more severe as compared to the first phase. So monitoring is important in such cases. So what should be the duration of monitoring after the episode of anaphylaxis then? So currently there is little evidence to guide the optimal duration of observation. Australasian Society for Clinical Immunology and Allergy, they recommend clinical monitoring of a patient for a minimum of 4 hours after the large dose of adrenaline. Patient should be strongly be considered for overnight hospital admission for at least 12 hours if they present with severe or protracted anaphylaxis requiring repeated dose of adrenaline. The chances of having biphasic reaction is more in them. They have a history of severe or protracted anaphylaxis in the past. They have certain underlying concomitant illnesses like severe asthma, history of arrhythmia, systemic mastocytosis. If they live alone or at some remote place, if they present in the evening hours, then they should be advised overnight stay. So as we know, the recurrences are more common. So a long-term management plan should be made available. Why? Because the data indicates that the recurrence of reaction from various studies, the incidence or the prevalence is around 26.5 to 54% of annually during a follow-up period of 1.5 to 25 years. So identification of triggers by detailed history should be confirmed by in vivo or in vitro test. A written action plan should be given to patient if they encounter anaphylaxis, what should be done. They should teach back when to administer epinephrine and emergency medications. Availability of epinephrine for prompt administration as early as possible should be made to them. Management of risk factors for fatality like poorly controlled asthma and cardiovascular disease should be dealt with. And how to prevent recurrences should be taught. They should be taught to avoid allergens. They can be offered allergen immunotherapy or desensitization. Medical identification bracelet or wallet card. If a person is allergic and has gone to some restaurant or somewhere, they should always wear the bands which are available. They should be registered in certain electronic or paper medical record for the suspected triggers, so that in case of emergency, people may recognize. And education and training is important. And follow up and reassess for veracity of original cause of anaphylaxis is needed. Now, as we know, EpiPen is given in abroad for self-injection. Their auto-injectors are ideal, but in our country, they are not available. So what can be used then? Then we can keep these things ready in our clinic for certain unavoidable situations, and this can be offered to patients also. So normal injection adrenaline can be used, and 2 syringes should be made available, 0.5 ml, and kept in a opaque container, and can be kept for 3 months at room temperature protected from light. So we keep in our OPD setup in our table always the adrenaline. A date should be mentioned when it was filled, and intermittently we should look at the color change. If the color has changed to straw color, then we should discard. And if it is clear, we can use. Why 2? Because initially after giving, a child may require second dose, so a second dose should also be kept in place. Sometimes you can mark for a ready reckoner type of thing, 0.15 ml marking, 0.3 marking, and 0.5 ml marking. So the ready reckoner should be kept always in the OPD on a table or some corner. So take home messages. We should always keep a low threshold for diagnosing anaphylaxis. Food allergy is most common trigger in children. treatment is adrenaline, adrenaline, and adrenaline. If in doubt, administer adrenaline. Positioning is important. Monitoring is required and must to observe for biphasic reactions. All clinics should keep injection adrenaline ready to combat anaphylaxis post-vaccination or post any medication. And patients, parents, caregivers, and school authorities must be sensitized and trained to recognize anaphylaxis and provide first aid. Thank you.
Thank you, Dr. Vikram Patra, for your excellent presentation. First of all, I would like to say that your first slide, memorizing Professor Dr. Major Nagaraju, I have taken aback because that was really nice. And second, your talk was very crisp, very informative, and point, very important sense that's very crisp. And you know that positioning is very important. And the last slide also, it was really good. And I would like to thank Dr. Vikram and also Dr. Jijo, who has organized this meeting. Thank you so much. Now I hand over the mic to Dr. Anand Keshavan, my lifetime friend, Dr. Anand.
Thank you, Jayama sir. Very good morning. At the outset, I would like to thank Dr. Jijo Joseph and other organizing committee members of this meeting. So we'll have another important common topics. That is urticaria, both acute and chronic urticaria. I think most of this is one of the commonest problem. We are allergic problem what we are seeing in our regular practice. It may be acute or chronic, maybe IgE mediated or non-IgE mediated. And there are so many etiology, especially in children. It may be infection, or it may be vaccine, it may be food allergy, or it may be more common, it may be drugs also. There are, I think there are many new drugs are there. I think we have an apt person, Dr. R.K. Gupta from Jaipur. Good morning, sir. Good morning. R.K. Gupta is from Senior Professor, SMS Medical College, Jaipur, and he's in charge of gastroenterology division. He was National Executive Board member for 4 times, and also he's also a National Executive Board member of Medical Education Unit. I think I'm from North Zone, I am from the South Zone, and also he got many publications, and also member of many IAP teaching module. So over to Dr. R.K. from Jaipur.
Thank you, sir. Thank you so much. Am I audible, sir?
Yeah.
I'm highly thankful for my nice introduction by Dr. Anand Keshavan, sir, our Vice President last year. And my sincere regards to my teacher, Dr. Sukumaran, sir. And it's the person who brought me into the IAP main field. My sincere regards to him. And my deep homages to my co-colleague in the EB as well as our Vice President this year, South Zone, Dr. Nagaraju sir, who is the pioneer in the pediatric allergy. And my regards to Dr. Parmesh sir, Dr. Jayaraman sir, Dr. Sibi, Johnny Sebastian, and EB members of the Kerala, Jason Unni sir, Jaikumar sir, Riyaz sir, and Nandkumar ji. And to all the persons who are involved, especially Jijo, my friend, Dr. Josh Yusuf, my co-AB last year, and CP Korean Philip, and all the persons who have given very nice mesmerizing talks, first starting with the Dr. Reddy sir, Upinnaran Reddy sir, followed by Dr. Narayan Modi, and then Dr. Bijania, Vinod Ratagiri, and now Vikram Patra sir. So I just want to discuss about urticaria. And I also want to thank Dr. Alexander and Judy Thomas, Organizing Secretary and President for this NVCon. This is the Conference of Allergy as well as Environmental Group. So we'll discuss about the urticaria, approach to acute and chronic urticaria. So this is very important, and urticaria is a common disorder. You can find it in around 20% of the children sometimes. It's not moving. Okay. So urticaria is a vascular reaction of the skin marked by the transient appearance of smooth, slightly elevated patches, which are erythematous and associated with severe pruritus, or we can call them hives or the weeds. So, but it is not a simple thing. There are three important things which are important. Central swelling of variable size, surrounding reflex erythema, and associated symptoms of pruritus or burning. These are the things that makes it a wheel or hive that you can see. This is the central swelling followed by erythema, and there is some itching in this. It resolves usually within few hours and mostly by the 24 hours. In this angioedema, this is associated in around 20 to 40% cases of urticaria up to some extent. And this is the submucosal or subcutaneous swelling. You can see this is the subcutaneous or submucosal swelling, which involves basically lips, eyelids, back of the hands, feet, scrotum, and the cheeks. These are the things, and it resolves in 1 to 3 days. It takes longer time, and it causes pain more than the itching. There is no itching, but the pain and the burning sensation, tingling sensation occurs. And when the severe angioedema is there, there is a risk of anaphylaxis. And both can coexist as relapsing or remitting episodes. Urticaria may be of two types, acute and chronic. When it is for less than 6 weeks, it is acute. And when it is more than 6 weeks, but every week it is there at least twice per week, that is chronic. It's not like that. If it occurs after 6 weeks, it is another episode of acute urticaria. So in the acute urticaria, most episodes last for short duration, while in the chronic urticaria is distressing and disabling, and this is the main problem for a pediatrician. But luckily, chronic urticaria is very less often than the acute urticaria. So this is the pathophysiology. I will not go into the details. It's a very big in details. The activation of the mast cell or the basophils, they release multiple mediators, including histamine and the vasodilator like platelet activation factor and the cytokines. They all lead to localized swelling of the uppermost layer of the skin and the extravasation of the plasma. So there is release of the local mediators, vasodilatation, sensation through the nerve endings, and if it occurs in the dermis, it is urticaria. When it occurs in the deeper dermis and subcutaneous tissue, it is angioedema. So these are the four things that occur: sensory nerve activation, vasodilatation, plasma extravasation, and cell recruitment. They all lead to urticaria lesions, and these are the factors: histamine, platelet aggregating factor, serotonin, tumor necrosis factor, tryptase, interleukin 1, 6, 10, 13. We all know about interleukins after this COVID. Previously, they were not available in any of the good centers. Only in the research labs they were available, but nowadays IL-1, 6, 10, they are available everywhere, and they are being done in medical colleges. And this is the another table which is showing in detail that what are the various causes, IG, and all these causes which may lead to, these are the mode of actions, and this is the activation of the mast cell or the basophil. This is the activation by all these factors. So this is the activation of the mast cell, which leads to so many mediators, local mediators, mainly histamine, platelet aggregating factor, serotonin, and various interleukins, and the nerve and activation, pruritus, vasodilatation, erythema, extravasation, wheel formation, cell recruitment, reinfiltration. So this is another one in which immunological type of urticaria, non-immunological type. I am skipping this slide because of the time. And the lifetime prevalence of urticaria is up to 20%. And the point prevalence is 1%. It's not uncommon in children. In certain studies, it is found to be more common in children. Male to female is equal in children, but in adults, commoner in female. And it has been found in up to 2.5% of the children below 14 years. This is higher than the prevalence in the adult. And the chronic urticaria is found in 0.7 to 0.8%. This is the etiology. This is the very wide etiology. And in certain cases, we cannot find etiology also. But the etiology is various viral infections, hepatitis A, B, infectious mononucleosis, various bacterial infections, H. pylori, parasitic infestations, and the fungal infections. There are so many drugs, especially NSAIDs, ACE inhibitors, aspirin, antibiotics, and mepridine, codeine, environmental changes, allergens like grass, dander, insect sting. There's 8 foods which are common food allergens. They all can lead to urticaria: egg, milk, wheat, soy, peanut, tree nut, fish, and the shellfish. Autoimmune diseases like collagen vascular disease, SLE, polymyositis, dermatomyositis, thyroid disorders, autoimmune thyroid disorders, hormonal changes during the menstrual cycle, and celiac disease. This can also lead to urticaria. Physical agents will learn heat, cold, sunlight, pressure, vibration, stress, and anxiety. So viral infection is the commonest cause of acute urticaria, while the autoimmune hives are a very important cause of chronic urticaria. It's one of the common causes of known causes of chronic urticaria. So this is immunologically mediated, maybe Ig mediated or non-Ig mediated. And this is the non-immunologically mediated because of the contact allergens or the cold temperature changes, pseudo-allergens, light, medications, direct mast cell degranulation, physical stimuli, mastocytosis. So these are the etiological causes of the non-immunological mediated. So this is a simple slide. I've taken it from the CADE module with my regards to Dr. Narayan Reddy sir. This is the urticaria class. It's a very wonderful slide. This is the less than 6 weeks of spontaneous wheals or angioedema or both, that is acute urticaria. And when it is more than 6 weeks, continuously for every week, then it is chronic urticaria. When the wheals can be reproduced with the triggers known, this is the inducible urticaria. When we are not knowing the triggers, it is the spontaneous urticaria. So spontaneous is 75% of the chronic, and inducible is the SINDU. This is the 25%. This is again of 2 types. There is autoimmune markers in which you can find functional autoantibodies to either IgE or IgE receptors. So either FC, IgE or the IgE receptors. This is the autoimmune chronic spontaneous autoimmune urticaria, and this is the chronic spontaneous idiopathic urticaria where we are not knowing the cause. So this is again, this is of 2 types. You can discuss chronic urticaria. This is the spontaneous one, which is the commoner one, and this is the inducible one. You can see this, the dermographism, delayed pressure urticaria, cold urticaria. It may be because of the cold, heat urticaria because of the heat, and contact urticaria because of the contact of certain things, aquagenic when it is with the water, and solar when it is with the sunlight or the ultraviolet range. So this is chronic inducible urticaria, very nice. See, you can see this, the urticaria factitia, that is the symptomatic dermographism. Even stroking or scratching of pressure, there is urticaria, and it disappears into 1 hour. Delayed pressure urticaria, when the pressure is applied for 30 minutes to 12 hours before onset, pressure for half an hour and the urticaria will appear after 1 hour to 12 hours. Cholinergic urticaria, when the elevation of temperature because of exercise induced or hot water or the emotions or the spicy food. Cold contact, when it is to the cold air or the cold water. Heat contact, warm subject. Exercise induced because of the exercise, and aquagenic, skin contact with water at any temperature. This is aquagenic. So they are not able to come in contact with the water. So this is the evaluation part. The diagnosis is clinical, and the first step is history and physical examination. So these are the most important things: history and the physical examination. And the history taking is essential as the exacerbating triggers are variable. So we have to take a very, very detailed history that we'll discuss. So in the history, time of the onset of the disease, then shape, site, frequency, distribution, and associated angioedema. The angioedema is more severe, the etiology may be slightly different, and there is a risk of anaphylaxis. Associated symptoms like bone pain, joint pain, fever, abdominal cramps, they lead to other etiologies. Family and personal history of wheals and angioedema, induction by physical agent or exercise for the inducible urticaria, and relation with the daytime, relation with the weekend, relation with the menstrual cycle, relationship with the holidays, relationship with the foreign travel. So all are required as in routine cases of allergic disorders. relation with the food or the drugs. This is very important. NSAIDs and ACE inhibitors can lead to urticaria, and occurrence in relation to various infections and stress, and history of allergies, infections, autoimmune disease, GI problems, previous therapy, duration of therapy, and diagnostic procedures. So this is the history that we need to know. Then comes to the physical examination. So physical examination, we have to examine in toto the whole general examination as well as the system examination. And then we have to find out the things. So now coming to acute urticaria. So diagnostic workup in acute urticaria does not require the significant diagnostic workup as it is self-limiting. We are not worried about acute urticaria, but when we suspect the food allergy, then we have to be important, because we have to identify and definitely say that it's food allergy. We have to do elimination and re-challenge, or some other eliciting factor like NSAID. So we have to find out whether there is any relationship with that, and we have to confirm it by first elimination and then by the challenge test. Allergy test as well as educating the patients may be useful in such patients. Now, workup in chronic urticaria is very long and very difficult for a common pediatrician, even for allergist. But we have three aims in the workup: to exclude differential diagnosis, to assess disease activity, disease impact, and disease control, and to identify triggers of exacerbation or wherever indicated any underlying causes. And further diagnostic procedures to reveal underlying causes with long-standing uncontrolled disease need to be determined carefully. Because in many cases, we continue to go for investigations, and we do not find much value of those investigations. So we should be very careful and schematic in diagnostic workup in the chronic urticaria. So these are the tests for the chronic inducible urticaria. If it is being suggested by the history for symptomatic dermographism, you mild stroking of skin with the tip of the pen or the tongue blade, then you can see there's the dermographism or the formation of a line or urticarial line. The delayed pressure urticaria, a shoulder sling with the weight of 7 kg, typical school bag for 15 to 30 minutes and C for 24 hours. In cholinergic urticaria, exercise with the stationary bike for 15 minutes beyond onset of sweat, or passive heating of one arm to 42 degrees centigrade with water bath or the whole body immersion in the water. Cold urticaria, ice cube test for 5 minutes on arm temperature threshold test if available. So we have to keep ice cube for 5 minutes, and you will see urticaria there. Heat contact urticaria, the application of test tube containing warm water at 44 degrees centigrade. Exercise induced, the same like cholinergic, but here only treadmill exercise for 10 minutes. Aquagenic, application of water at 35 degrees to the trunk or water immersion for more than 10 minutes. So these are the tests for chronic inducible urticaria. For chronic spontaneous urticaria, so this is the big group, and we could not find causes in most of them. So this is the problem. So these are the three basic tests. We have to go for CBC with DLC, CRP, and ESR. This is very important. And extended workup on the basis of history for the identification of various underlying causes and to rule out possible differential diagnosis. These are, you have to find out UTI, you have to see for parental carriage, and H. pylori is very important. We have to think about the autoantibodies. For that, we can go for autologous skin serum test, ASST, and thyroid gland disorders, though they are not common, but they are found in around 5 to 10% cases. So you have to go for thyroid hormones and autoantibodies. They are the two thyroid autoantibodies, but it's the anti-TPO and anti-thyroglobulin. So we have to go for that, and they are available easily. And skin test or the allergen avoidant test, depending on the history, if the person is having allergy on exposure to some park, or is having allergy while coming to home only on the holiday, or he's having allergy in the office environment, or he's having allergy in some place like some room. It's like wherever you find that there is some relationship with the allergy, you have to go for that. And there is concomitant SINDU, then we have to go for we have to search for the concomitant SINDU. And severe systemic disease, we have to go for tryptase test if we are having severe angioedema, because the angioedema may be sometimes dangerous if it involves the larynx. And in certain cases, especially when the urticaria persists for more than 24 hours, usually a typical urticarial lesion, it relieves by 24 hours and the next lesion appears. But it persists for more than 24 hours, or the itching is less, then there may be some other problems and we have to go for lesional skin biopsy. So this is autologous serum skin test. It should be considered a screening test for autoantibodies, and it should not be routinely performed in every case. And negative ASST exclude an autoimmune pathogenesis. Here we have made three things. One is the histamine, that is the positive control, sodium chloride 0.9%, that is the negative control. We take serum of the patient and we inoculate itself here. So this is the ASST, and then we can find out the autoimmune basis of the chronic spontaneous urticaria. So to know the problem of urticaria or how much troublesome urticaria is to the patient, this is the urticaria activity score. This is again important in knowing how much the patient is in problem, and we have to monitor the treatment. We want that this urticarial activity score becomes lesser with our treatment. So you see, this is the 3 score 0, 1, 2, 3, and based on the wheels and the pruritus. When wheels are less than 20, there is a 1 score, and when wheels are more than 20, it is more. It is 20 to 50, it is 2 score. More than 50, it is 3 score. And the pruritus mild but not annoying, it is 1 score. Moderate, troublesome, but no activity with the no interference with the sleep, this is 2 score. When it interferes with the sleep or the daily activity, it is 3 score. So per day score may be up to 6, and we have to take a score for 7 days. So 6 into 7, that makes 42 is the uppermost score. If it is less than 6, it is well controlled. 7 to 15 is the mild. 16 plus is the partially controlled. 16 to 27 moderate, and 28 to 42 is the severe disability. So severe activity. So this is the urticaria activity score, and we should make habit of using this scoring system in every patient of chronic urticaria. So this is very important, as told by my friend Dr. Jijo, to discuss about the management of urticaria. And the goal of the treatment is to treat the disease until it is gone. So this is the goal in every disease where we are doing. So if we can, then we should. So it is the thing. And the therapeutic approach to chronic urticaria, identification and elimination of the underlying causes, avoidance of the eliciting factors, tolerance induction if possible, and the use of the pharmacological treatment. So the pharmacological treatment comes at level 4. Dear friends, this is the thing, that the pharmacological treatment is not the first treatment. You have to take a good history, and identify underlying causes, try to find out triggering factors, and if it is possible, then we go for tolerance induction, and then we use the pharmacological treatment. And the treatment should follow the basic principle of treating as much as needed and as little as possible. So we should have a balance between the lowest possible dose and the disease control. So that is the thing. So that means we can go stepping up or stepping down. Both approaches can be taken. So this is identifying and eliminating or avoidance of eliciting factors. This is the exact diagnosis, the prerequisite, and it is difficult in certain cases. But yeah, once you suspect a case, it should be elimination test and then re-challenge test. So double-blind provocation test if possible. Otherwise, elimination and re-challenge, that is important. So these are the important things. Certain drugs, especially NSAIDs, ACE inhibitors, penicillins, penicillin derivatives, and certain, you can see, morphine and pethidine. So these are the drugs. And this one more drug, anaphylton, that we are using. So that is again causing certain times this allergy. And the physical stimuli that we have discussed, that heat, cold, pressure, vibration, sunlight, everything, these things can lead to urticaria. Eradication of infections and infestations. infections like H. pylori and even other viral H. pylori infection and infestations, certain worms in the body, they can again lead to, inside the gut, they can lead to urticaria, but though not that common. And reduction in the physical and emotional stress, that is again important, because it is the stress, whenever there is physical stress or the emotional stress, the urticaria will worsen. And the dietary treatment, if there is food allergens, we have 8 common allergens or other also. So we have to look for milk, soya, egg, fish, tree nuts, peanuts, shellfish, etc. And the pseudo allergens to for if they are aggravating the urticaria or they are causing the urticaria. This inducing tolerance is possible in certain subtypes of the urticaria, like cold urticaria, cholinergic urticaria, solar urticaria. But this tolerance is lasting for few days. It's not like that once you have got tolerance, it will last for lifelong. So thus a consistent daily exposure to the stimulus just at threshold level is required to continue this tolerance. So first get tolerance by just at the threshold level, you have to give stimulus. And this induction is usually sometimes not accepted by patients, because cold urticaria, daily cold baths or showers are needed to achieve this. And sometimes it is not possible. And sometimes it leads to urticaria if it is above the threshold level and parents are then worried. Symptomatic pharmacological treatment is the aim for the symptom relief. The general principle is to use as much as needed and as little as needed. And the main options are to reduce the effect of mast cell mediators like histamine. So we want the drugs which reduce the effect of mast cell mediators like histamine, PAF, and others. So especially we take the antihistaminic drugs for the treatment, but other anti-inflammatory like steroids may also be used. So antihistaminics, the second generation are used. First generation antihistaminics have no role nowadays in treatment of urticaria in children. And they work as the inverse agonist with preferential affinity for the inactivate state of the receptor and stabilize adrenaline this conformation, shifting the equilibrium towards the inactive state. So H1 receptors, they bind to H1 receptors and they block those receptors. So the histamine released will not able to bind to these H1 receptors. And so that we need to give them for a longer period, for continuous period, sometimes for weeks, even sometimes for months. In the physical urticaria, when you know the cause, then intake of antihistaminic 2 hours prior to the activity may be sufficient to prevent the disease. Now, why we are saying that the first generation should not be used? There are so many reasons. And dear friends, we are scientists. We know that unless there is reason, we will not follow it, because the first generations, they lead to immediate relief in urticaria, but they cause certain problems. That's why we should not use them. They have pronounced anticholinergic effect, dryness of the mouth and the dryness of nose, and they have sedative actions on the CNS. The child is drowsy, depressed, irritable, interactions with the various drugs affecting CNS like analgesics, hypnotics, sedatives, mood elevating. So it is very troublesome in the adolescent, interferes with the natural sleep. So REM sleep is disturbed and it has impact on the learning and the performance. So the child's school performance, play performance, exam performance, driving, thinking, they all are disturbed. So never use, not to use first generation antihistaminic. And these are the common examples: chlorpheniramine maleate, promethazine, diphenhydramine. This is the slide that we can use. These are the second generation antihistaminics which are available. And we have so much of the wide availability. So I have made this table for the ready reference so that we can give cetirizine from 6 months onward, which is cheap and easily available. So we are driven by sometimes by the pharma persons that this is good, this is good. So all antihistaminics second generation are very good. So they all are having minimal sedations. They do not penetrate. They do not go into CNS. So the blood-brain penetration is less, and they have got long-lasting effects. So even they can be given OD doses, cetirizine, that can be given up to 6 months, that is by the 0.25. The levocetirizine that can be given by 0.12 milligram per kg above 6 months. The desloratadine that again can be given. This is the dose for 12 to 18 years, 6 to 12 years, 2 to 6 years. And the loratadine is again very good drug. And here you can give up to 2 years or onward. This is again very good drug. The fexofenadine has got advantage that this has very less, or you can say that there is no sedation at all, while the cetirizine may have very mild sedation. And in few persons after cetirizine, they have difficulty in rising up in the morning. This effect is less with the fexofenadine, and this can be given more than 2 years of age by the 30 milligram BD, or sometimes in the 6 to 12 years, 30 to 60 milligram BD. In the adolescent, you can give 120 milligram, but you can use higher dosage also. This belastin is a new molecule in India for last 2 years. It has got wonderful results, and it can be safely given in more than 6 years old children. But in 2 to 6 years, certain there have been studies about safety, but still the US FDA has not approved it. But there are a safety profile studies are there available in more than 2 years age group. And then again, rupatidine. These are the two new drugs, but they are very costly. So I think if you are using the standard levocetirizine, cetirizine, or fexofenadine, loratadine, that is okay, and you will have the same results. And as you have to give for long period, the cost also values. But this is the question: in case of failure of second generation at the standard dose, what are the options? This is a common question. So we have to, in the more than 12 years, you can safely increase the daily dose up to 4-fold. First to double the dose, and even if there is no effect after 7 days to 14 days, you can again double. So up to 4 times of the recommended dose given in this table can be given for treatment of urticaria. Less than 12 years, though, studies are not available for up to 4 times dose. But increasing dosage can be evaluated. Double the dosage, studies are there, and that is safe. So you can safely double the dose, and sometimes you can slightly more increase the dose, and you have to keep the child under strict monitoring. But suppose if the child does not respond, then a course of treatment with a different molecule can be tried. Though various persons, they do not agree. They say that all second generation antihistaminics are same. If one is such failed to someone, then he will not successful in other one. But as the omalizumab and the other alternatives are not easily available and very costly, so we can always have, in my opinion, we should use second molecule, and I have found this method useful in certain cases of urticaria.
That time, please, sir.
Sir, just only two more slides, sir. Only 2 slides. So this is the thing. And other agents, oral steroid short course up to 10 days can be given in case of the failure to the 4 times dose. And montelukast is not recommended as monotherapy, but there are certain studies that it can be given as double therapy or triple therapy in certain cases of refractory urticaria. Yesterday only I was going through the Nelson, and they have recommended that we can use antihistaminics H1 second generation along with this H2 blockers as well as montelukast as triple therapy in certain few cases. And omalizumab, though it is available in India, it is costly and it has to be given monthly for 6 months. So this is anti-Ng monoclonal antibody can be given refractory and cyclosporin in certain cases. So this is the last, second last slide of my presentation. This is the summary of the SI guidelines. You can see the first generation, if inadequate control after 2 weeks and the symptoms are intolerable, you can increase the dose double, and then you can increase to 4 times. If still inadequate control, then you can give omalizumab. And if there is still inadequate control and within 6 months or earlier, then you can give cyclosporin. But these two should be given with the person who is fully busy in the allergy and who is doing the full allergy part. So they should be given under strict supervision. These drugs are not, they are having certain side effects, and we have to monitor those. Up to this level, a person trained in allergy or a routine pediatrician who has been trained in various allergic CMEs can use it. So this is the very nice slide that we can see that in the chronic urticaria, there are two things: chronic spontaneous. This is the summary of the chronic inducible urticaria. So if it is yes, then it is inducible. And food, you have to find out the causes. This is the food or recurrent angioedema, hereditary fever, vasculitic urticaria when it is more than 24 hours, delayed pressure urticaria, you have to go for a specific test. So these are the things, but the basic tests are CBC with DLC, CRP and ESR. And few persons are saying that especially in North India, urticaria may be caused by celiac disease and the autoimmune thyroiditis. So in every case of chronic urticaria, you should go for IgE, means thyroid antibodies, as well as the anti-celiac, that is the TTG antibodies. But I think that is not the case in the South India. But in North India, we can have chronic urticaria, we go for celiac disease serology also. Thank you so much. Thank you for giving me this opportunity. I'm highly thankful to organizing team, Dr. Hari Kumar ji, that is the president of the ACSG Kerala, Jos Usaf, who is the president of the PAI Kerala, and my friend Jijo Joseph John, who is the president of the IAP Patna Pitta, and CB Phillips, Alexander Sir, Judy Thomas, and foremost our president 2022, and my dear friend and my senior, Dr. Ramesh Kumar R. Sir. I'm highly thankful to you all for giving me this opportunity.
So thank you, Dr. R.K. Gupta, for the wonderful talk on acute and chronic urticaria, pathophysiology, treatment, and other detailed description. Since we are running short of time, please answer the questions in the chat box.
Yes,
I think 5-6 questions are in the chat box.
Yes.
Once again, on behalf of the Dr. Jayamara and myself, we would like to thank the organizing committee members for giving us this opportunity to chair this session. Thank you. Thank you.
Thank you, sir. Thank you, Jagabal sir and Andageshwan sir. Thank you, Arke Gupta sir, for that excellent
Thank
session.
you.
There are a
Thank
lot
you,
of
sir.
questions coming in, and we are sorry we can't take it up on discussion because we are sure it will take another half an hour at least for a very good discussion going forward. Now, we have our own Parmesh sir, the doyen in the field of allergy, waiting for us for the next talk. For introducing sir, we would like to invite our mentor, Sukumaran sir and Nandakumar sir, to taking over the next session. Over to you, Sukumaran sir and Nandakumar sir. I will just unmute Sukumaran sir. Sukumaran sir, you can unmute yourself, sir.
Hello.
Yes, sir.
Am I audible?
Audible, sir. Audible.
Okay.
I just unmuted Nandakumar sir.
Okay. It is good afternoon, everybody. My beloved friends, Dr. Jijo, Dr. Paramesh, other speakers of the day, R.K. Gupta, and others. It gives me great pleasure and privilege to be here to chair this session of my own guru, my own beloved friend, Dr. H. Paramesh. Sir needs no introduction to this audience. If I am going to introduce him, it will be suicidal, I know. So I'm not going for that. But I just want to highlight a few points. He is a person who is an international figure in allergy and environment. He has started 3 chapters. He was the chairperson of the 3 chapters of Indian Academy of Pediatrics. The respiratory chapter, allergy and immunology chapter, and also the environmental chapter. He, along with Dr. Nagaraju, has started the allergy and environmental chapter of Indian Academy of Pediatrics. And also, he is a representative of India from India in WHO to discuss about the climatic changes. And at present, he is the visiting professor of the Vita Center for Climate Change in Indian Institute of Science, Bangalore. He is the director of the Lakeside Medical Education Trust and also hospital previously. And he is an international figure. He is the outstanding environmentalist, allergist, and pulmonologist. and he's going to talk on air pollution and child health. As I said in the morning, air pollution is an important problem in all child health problems. We've seen that in more than 40% of child health problem, some environmental health problem will be there. And also it is seen that more than 4 million children die due to air pollution. So any child with a medical problem or a surgical, even a surgical problem, you must take a detailed history on environment. Look for an air pollution, outdoor pollution, or indoor pollution in all our children. And also you can see that the air pollution can lead to recurrent respiratory problem. You can produce asthma flare-up under 5 years. You can produce recurrent ISOM. Even sudden infant death syndrome can be there due to this environmental pollution, especially the outdoor pollution. And with these words, I have great pleasure to welcome Dr. Paramesh sir to you, and I request sir to start his talk on air pollution and child health. Sir, please.
Professor Sugumaran, my dear friend, or brother-like, thank you very much for a kind introduction, as a matter of fact. And at the outset, I have to extend my sincere thanks, none other than Jiju Joseph John, the president of the IAP, Patanam Titta, and branch of IAP. He fixing the date, fixing the time, my convenience needs to change twice. I am ever grateful for that. Affection and love he showed, and things like that. And other chairman, Nanda Kumar, I will also thank you, sir. In addition to that, we have the organizing committee, Roy Alexander, Judy B. Thomas, and Dr. Balachandar, and we have Ramesh Bajani, our chairman of environmental chapter. And if it is there, MKC Nair, I don't think I can see him. My friend Anand Keshwan, Jay Kumar is there. With all these things, it's an honor for me to speak about topic on the air pollution impact on children. Impact on children, not only respiratory, various other things come into the picture. And two speakers have spoken earlier, Ramesh Bajani and Ratagiri. They did mention about these things. I like to focus on all these issues as a matter of fact. Next slide, please. Next slide, please. Okay, the flow of thoughts comes this one. I'd like to spend about half a minute or so in historical background. The health is the most important thing, especially for the 2020 onwards. Whole world knows about health is a major issue of the world to save our life. What are the basic human survival things are needed? Why we need air? What is the air quality index means to us? Impact of air pollution and with health on health, what proof we have to substantiate? That's what people do need it. Causes for the air pollution. What are the measures you are taken to mitigate? How best you can propagate further? Does our government, current policy makers have taken an initiative in reducing the air pollution? What is the take-home message? In these issues, we'll go further. Next slide, please. Well, historical background, if you look at that, in the 13th and 17th century, environmental crises were due to the air pollution, mainly from the rapid urbanization at that time, increase in the density of the population, change in the use of fuel from wood to coal, producing a lot of fossil fuel. In 1733, Dr. John Arbuthnot's scientific paper says, and inner city children, they suffer much more from lung problem from the air quality, poor air quality. High death rate has been observed in the children living in the urban area than in the rural area from the sulfurous steam fuel coming from the fossil fuel, as a matter of fact. Next slide, please. So in the same way, the British people have taken all the previous slides, taken the thousands of skulls belonging to different age group. They did a CT scan, all of them, find out what is the incidence of the sinusitis. When there was no fire was there, in the Bronze Age and Iron Age, it was only about 0.5% of the prevalence of the sinusitis from the air pollution. When the Romano-British age, they found out the fire, they started cooking the food outside. Then it's gone up from 0.5% to 3%. when the civilized person, again, we civilized, in Anglo-Saxon era, we started cooking food inside the house. It's gone up from 3% to 7%. Then a lot of people started suffering. Then the greatest invention happened at that time in the world, as a matter of fact, in the medieval age, that had happened. What is that? In medieval age, from 7% to, it came down to 3.5%, mainly from this new invention, which has got a greatest impact on the human health in the world, is finding out the chimney to go, smoke to go up. And this is what the historical background we have, enough data to substantiating. Next slide, please. If you look at the air pollution, which kills 6.5 million people every year, and air pollution, this is 3 times more than the HIV, AIDS, tuberculosis, malaria, putting all diseases together. 70% of the disease caused by the environmental pollution are non-communicable diseases. In them, 70% non-communicable diseases are from the air pollution. Look at the different countries where the air pollution. India comes first, next comes China and various other countries. 70% of the pollution is from the air, and another 20% from the water, 10% of the chemicals and other things, soil pollution, as a matter of fact. Next slide, please. Now, health is the most important. We got independence 74 years ago, by 15th, entering the 75th year. We got the liberation from the British rule, but we never got the freedom. What is the freedom? Freedom for the illiteracy, freedom from ill health, freedom for ill wealth. These three is a must. A country to progress with values. Development is one thing, but I want a country focused with the values. That is progress. We need good health. If you have a good health, you work more, you earn more, your wealth economy increases. Then if you have a good wealth, you have a good quality education and also care for the good future health. And what are the 3 important basic things you need? You cannot live without breathing air more than 3 minutes. You cannot live without eating food more than 3 days. You cannot live without drinking, without drinking water 3 days, without eating food for 3 weeks. These are all the 3 important factors, as a matter of fact. Next slide, please. If you look at these things, next slide. So 90% of your energy to mobility comes from the air, what we breathe. 10% come from the food, 1 to 2 kg, what we eat per day. Drinking water 2 to 3 per day, that contribute only 10%. So how much air we need? We need 10,000 liters of air to breathe every single day to get 500 liters of oxygen per day. That's only for sitting idle, not moving anything. That much oxygen we need it. That comes about nearly 30 rupees per liter. Amazon cost 15,000 rupees. We get oxygen every day. We need oxygen every day. To move 1 liter, burning 1 liter of petrol, to move 10 kilometers, your vehicle needs about nearly 1,700 liters of oxygen. For that, the engine has to suck 8,500 liters of air, forget that much oxygen to move about 10. So it comes about nearly 50,000 rupees per day. This is nature is providing us that. We are the one degrading this nature. It's very difficult. We are in the very critical stage, crucial stage to survive. Next slide, please. Next slide, please. So when you say air quality is very important, as a matter of fact, air quality, we have pure air, we have oxygen about 79%, oxygen 20%, carbon 4%, and that gives the osmotic pressure of the partial pressure of 760 millimeter mercury, and various components is there, as a matter of fact. Air is a mixture of many gases, moisture, and some inert materials, as a matter of fact. And what we produce in the pollutant, nature has self-purification process. The imbalance in the process causing the ill health, as a matter of fact. We cannot get a clean air anywhere in the world, as a matter of fact. Some pollution always will be there. When we measure the air quality, these are all the 7 components what listed here, we measure them. Most important is suspended particulate matter, 10 to 2.5, and also ozone. These are all the 2 important things. greenhouse gases, we worry about it. Next slide, please. Next slide, please. Okay, now, when you say 2.5 microns, particulate matter and gases, we have to worry about it. Particulate matter, 10 micron size, it will travel 10 yards to the 30 miles. 2.5 micron, this will travel to many hundred miles, as a matter of fact. That is a fine particle, 3% size of the air. It is a mixture of the solids and the liquids floating in the air. Those are all various components. 7 of them I've listed there: sulfate, nitrates, whole lot of things. So these bigger molecules deposit the upper respiratory tract, 10 microgram and above. Below 10 microgram up to the 5 microgram. So they will be in the major airways, and less than 3 micron, 2.5 micron, the alveoli, and also interstitium it goes there. It passes interstitium, produces the interstitial fibrosis, interstitial edema, interstitial pneumonitis, and diffusion of oxygen is a major problem. In addition to that, these small particles, they cross the interstitium with the 7 layers. Past the 7 layers, the radioisotope study shows it enters the blood within a minute. In 5 to 10 minutes, it spread all over the world. Radioisotope picture, what you see. Look at the lungs are the major organ. It has got impacted, and this particulate matter spread all over the vital organ, producing various other diseases in addition to the lungs, as a matter of fact. Next slide, please. How about the gases? Next slide, please. The gases which dissolves in the water. Next slide. Next slide, please.
Sir, you're muted yourself, unfortunately. Sir, kindly
Sir, you are
unmute.
muted. Sir, please
Parvez,
unmute.
sir?
Can you hear me?
Okay, okay.
Okay.
Fine, sir. Fine, fine.
The gases with water solubility and impact, that is, if it is high water soluble, it affects the upper respiratory tract, predominantly aldehydes, ammonia, chlorine, sulfur dioxide. Especially during Diwali time, sulfur dioxide is very high burning of the firecrackers. If it is medium water soluble, predominantly affects the trachea and bronchi. That is the ozone, not ground level. And if it is low water soluble, usually bronchioles, alveoli are involved by oxides of nitrogen and phosgene. Next slide, please. Okay. Now, these are all the studies have been, there a proof for that one. This is Calden and she had done a wonderful work, as a matter of fact, in Mexico. You are going to hear some of her beautiful studies. What she did was, they taken the children from the polluted area from Mexico City and not having a pollution that Veracruz City in the beach resort. They take a nasal mucous membrane biopsy, look at the ultrastructure of that one. She found out all the parameters of normal children living in the polluted area, including the goblet hyperplasia, where the excessive mucus production, and patch absent cilia. Cilia don't move the mucus, stagnation happens, get infected, damage happens, name it, wherever the mucus is there. We produce 1 liter of mucus in the respiratory tract. That stagnation produces all this problem for us. Next slide, please. And in addition to that, this air pollution, 2.5 micron, what is absorbed, and also it also goes to the placenta. In placental macrophages shown, presence of black carbon particle confirmed the electron microscopy also. This is a study has been shown, and that produces fetal thrombotic vasculopathy. The fetus in the mother's womb don't get enough nutrition because of clots in the placenta, as a matter of fact. Next slide, please. And in addition to that, these carbon particles has been seen in Dr. Dr. Kulkarni. She has shown in England, each carbon particle in macrophages, if the number increases, proportionately lung capacity decreases. Predominantly small airways are involved. It is a silent zone. Only you can identify measuring maximum mid-expiratory flow rate, as a matter, FEF 25 to 75. Next slide, please. The same thing has been shown by Dr. Kalapannavar in Davangere, 2 studies have been done the same way, as a matter of fact. How does this air pollution affect? Mainly from the oxidative stress and constriction of the muscles, smooth muscle, increase the permeability, fluid leaking, and impairments of beta-adrenergic response, not responding, along with the epithelial damage and airway hyperreactivity can be there. Usually hyperreactivity goes about 3 to 6 weeks after once you expose to an allergen, and alter release of the inflammatory markers and excessive mucus secretion. But body has got a way of handling this air pollution. What is that part? That is our pineal gland, what we got the third eye of the eye, between the 2 hemispheres of the brain. Melatonin, which regulates the sleep and wake cycle with other important function. Sleep is a must because during that time healing process happens. It protects the body from the damage from the free radicals. Antioxidants effect happens to that time. So if pollution is more, it cannot happen. Once you inhale the pollution, as a matter of fact, it takes about 4 weeks for a lung to heal. 1 hour inhalation of in major city, it takes 1 month lungs to heal. Next, please. Next. I think what are the impact? Impact has got to discuss about it. Major organ is from the pulmonary. Lung is the major organ, take the greatest impact. We have upper respiratory, bigger molecule, recurrent cold, cough, allergy, upper airway allergy, much more than the lower airway allergy. And laryngitis, bronchitis, like asthma, you know very well, we have got a 30-year study followed by ICMR study and Sukumaran study, is about 28% of the children have got asthma. Parenchymal disease, pneumonia, interstitial fibrosis, sleep disorder being the obstructive sleep apnea syndrome, chronic cough, spinal health, most important as a matter of fact, all these come from the lung, from the airway diseases. Next slide, please. In addition to that, this recent study shows traffic derived from the air pollutant exposure, pregnant mothers' impact on the fetus. What is the impact it has got? Almost Japan has got nearly thousands of cases. They have been shown. This study has shown increased coagulative problem in placenta, what I showed earlier, that if the clots are there, the small for dead children will be there, child don't grow weight in the mother's womb. If the clots are a little more, nutrition much more affected, premature birth have a 30% of the premature birth. If the clots is more, nutrition is very difficult for the baby from the placenta to transmit, stillbirths can happen. In addition to that, the antenatal exposure synergizes with the postnatal exposure with increase in susceptibility for the wheezing in these children, bronchiolitis in these children, asthma in these children. Wheeze is a major component all over the world. Next slide, please. So, around the world, preschool wheeze, I think Lancet in the year 2017, they communicated with 8 people globally to write their opinion about why wheezing has increased, what is their experience and all this thing. I'm one of them representing Indian subcontinent. I mentioned in our own study, we showed about nearly wheezing we have seen in 77.5% of children less than 5 years, 26.3% less than 1 year, as a matter of fact. Various other studies have shown, and the treatment and also we don't consider, we also discussed about. My friend in Poland has shown if the suspended particulate matter increase from 35 micron to 53 micron, there is 4-fold increase in the wheezing in the children, newborn children. This is the study has been shown. Next slide, please. And we have enough 30 years data, enough data, outdoor air pollution epidemiological data, indoor air pollution epidemiological data. Sometimes we may differentiate. We have enough substantial data. I don't want to go through all those things. We have substantial data in India to say, we have enough proof to say outdoor air pollution, indoor air pollution, as a matter of fact. Next slide, please. Now, what are the non-pulmonary diseases which will cause it? As you all know, air pollution is an invisible killer. Nearly 43% of the problem comes from the lungs, from the chronic lung diseases, 29% from the lung cancer. This month is lung cancer month, first lung cancer month, as a matter of fact, WHO. 25% of the direct heart attack directly from the air pollution, not from the pulmonary related, has been observed. 24% of the strokes coming from the air pollution. In addition to that, we have increased cardiovascular disease, increased blood pressure, and stroke increase, cancer, insulin-resistant diabetes has increased from the air pollution, and obesity related to that, baldness also related to air pollution. Next slide, please. And in third one, central nervous system involvement from the air pollution. Look at the healthy brain, look at the severe Alzheimer's brain. This also come from the air pollution, anosmia, autism, Alzheimer's disease, dementia, cognitive performance. Recurrent headache has been observed recently for the 2021 in Taiwan, where they found out without any headache with allergic problem come from the sinusitis. Maybe other one. They didn't have any one of those things. They ruled out all of them, migraine, headache, whole lot of things. This is come from the air pollution. Supporting evidence is it occurs in only urban children who are exposed to the air pollution, and also high density vehicle area only where pollutions were. Pollutant P.25 total hydrocarbon, methane, nitrogen oxide level is very high. In that area, constant headache has been seen in adolescent, in children. Next slide, please. The behavior problem on the polluted days has been seen. Increased crime rate, impaired judgment, worst test scores on polluted days, reduced productivity in work, immune suppressor has been identified as a matter of fact. Do you have a proof for this one? Next slide, please. Yes, I think this is Israel study shows as the pollutant level increases, the grade marks will decrease as a matter of fact, air pollution. Next slide, please. In addition to that, this is what I said from this is a study has been done in Ohio State, USA. And the rats, they made the rats inhale the polluted air, another group non-polluted air, clean air, and polluted rats has shown severe depression. How do you recognize depression in the mind? They love to swim, they love to sip this sugar water. They wouldn't do it. Other rats are doing it, these two didn't do it. That is the surprise. So it has animal studies have been shown. And also, as I said, my friend, Mexico City, she has done earlier what the nasal mucosa. And she took dogs from the polluted area, they studied their brain, and healthy air dogs, their brain, she found out increased phenomenal inflammation in the dogs exposed to the polluted area with amyloid plaques, like an Alzheimer's disease, which has not been there in the non-polluted area in the dogs. And also she has shown children in a polluted city showed lower test of memory, lower test of cognition, and lower intelligence. She has been done these studies also with proof. Next slide, please. The current Indian air pollution economic burden has been published by our ICMR and published in the December 2020 in Lancet. Our mortality in India from air pollution in children is 1.67 in the year 2019. Contrary to the belief, earlier indoor pollution has to be the predominant cause. Now we have indoor pollution, mortality has decreased by 64.2% between 1990 and 2019. Thanks for the Ujjwala program giving the gas cylinder, giving to the population. That has helped a great deal. The outdoor air pollution increased 115.3% mortality from that one. And economic loss also, India sustained economic loss 2019, US dollar 36.8 billion, 1.36 to the Indian gross domestic product, as a matter of fact. Next slide, please. And noise is the most important thing, as a matter of fact. And also our policy makers, our religious leader has to pay this attention, do something to avoid noise pollution so that people can have good sleep. Ill effects, what are the ill effects? High frequency deafness in the newborn babies. Prematurity will be there if they're noisy area, if they're living in. Intrauterine growth failure of the babies, sleep disturbance, and annoyance, headache, decreased work efficiency, poor school performance. All these things will come in there. Along with the air pollution, we have to popularize the noise pollution to the society. Let our leaders, along with the religious leaders, pay attention to this one, do something more about this one. Next slide, please. Next slide. Okay. Main drivers for the planetary change. Who is that? The biggest, most numerous animal on the earth. His breed, he wants to feed his breed, he wants to serve himself. That is the man who created this problem. Caveman longevity is 30 years. Now current man longevity is like 74 years. We are polluting more and more and more. Creative. We are the cause for all these things. We have to clean up this mess. So we are all aware that 2020, that the impact of the climate change from the air pollution on survival humanity is a priority. We should overcome the technological advantage we have in prevention air pollution, water pollution, soil pollution, sound pollution, chemical pollution, preserve the biodiversity. We have to live with the other animals and plants, a whole lot of things. Next slide, please. So this man, what we have done, he polluted the air. If you look at from 1756 up to 2010, this study has been shown how the carbon dioxide produced more of 275 was there before industrialization. Now it's gone to 380. Nitrous oxide gone 275 to 325. So, and also methane has increased, and stratospheric ground level ozone has increased, and temperature, it was minus 4 degrees centigrade, 1756, now is plus 4 degrees centigrade. We have to maintain less than 2 degrees centigrade by end of the century. Next slide, please. So it is essential because we are in the catastrophe of our planet. Because our carbon dioxide right now is of 400 to 450, we have to reduce it to nearly about 350. And temperature, we have to, it is going to go up to 1.2, 2.7. We have to reduce it 1.5 degrees centigrade. We produce 3 times more carbon dioxide than Mother Earth can manage. Mother Earth cannot able to manage. That's why we are facing all this flood, that whole lot of things, disasters. If we can't do this one, if the temperature increases 2.4 degrees, with the carbon dioxide 424, 600, irreversible damage is going to happen to this earth. If the carbon dioxide goes more than 6 parts per million, temperature reaches 5 to 6 degrees, no life can exist in this earth. Believe me, we are all going to lose our life. Everybody has to give life. Is it a proof for that? Yes, Venus is the one. Billions of years ago, people were there. It's not there anymore. Next slide, please. What is this cause for the greenhouse gases? This is carbon dioxide contribute 84%, methane 9%, nitrous oxide 5%, fluorinated gas 2%. What is the lifespan of these gases? Carbon dioxide, 80% of the carbon dioxide will be absorbed in the ocean. It takes about 20 to 200 years. And another 20% carbon dioxide, 1,000 years it takes. Nitrous oxide, 114 years, methane, 12 years. Next slide, please. And what are the sectors producing that ton? Most important sectors where we have to focus on, educate them. Number one is the industry. Number two is agriculture, forestry, and other land use, the second sector. Third is the transport. Earlier it was fourth. Now it is third one, building, construction, structural. These are all the 4 sectors. All these 4 sectors, most common cause is fossil fuel. 95% of the pollution, air pollution comes from the fossil fuel, predominantly coal. Next comes the oil. Is only 1% for the burning of the leaves, waste, and the agricultural waste. It comes a certain period of time. And cement industry, gas, and all, cement industry produce about 3%. We have to tackle this one, reduce the usage of the fossil fuel. Next slide, please. And these are all 8 sectors. We have to address that one. Health is a major component. Now everybody knows about it. For your health, you have to do this. You have to take care of the educating the industrial people, energy, change the energy, water and sanitation, hygiene, food going to be a major problem in future, and transport, and land use planning, labor, and housing, how to build the houses and all things, situation. These are all the sectors we have to educate to maintain the health, life on this earth to sustain. Next slide, please. So what are the measures? We had 3 important things as a matter. One is reduce the pollution at source by educating the sector. How? By setting up the guidelines, regulating the automobiles, and new energy sources we have to find out. remove the fossil fuel and what you are giving a lot of money, energy, banks are giving a lot of money for the energy source from the fossil fuel, that you have to stop it. Reduce the fossil fuel at any cost. Next is what is already existing. What can you do? Increase the greenery. There are ways, scientific ways are there. Ocean agriculture, scientific bases are there. Sustainable cities has to be done. Wherever the place, make greenery. If you spend 1 rupee to make a greenery, it saves your city about 34 rupees per year, per person per year. And population growth, because we are growing so rapidly, we have to reduce it as a matter of fact. Because demand has to be reduced to supply, to match the supply. Convert the gas into stone. There are technologies available. Carbon dioxide can be set, pumped into the ocean, make it as a rock, and we can use the same rock for the build of the future. It enhances financially, it is sustainable. And in addition to that, people who are already suffering, we have to care for, and also animals and all the things. Traditional food habits, encourage traditional food habits, good ventilated house, build our house to our needs, safety controlled medicine, we need it, and research to our need is a must. Think locally, act locally, propagate globally. In addition to that, when to policy makers, we have to take our white coat, black coat friends, legal activism also needed from us. Thank you very much. Next slide, please. Next slide. And individually, what we can do. So each one of us, in addition to the policy maker, I think the global average 4 tons of carbon dioxide per person is produced now. We have to reduce it 2 tons per person. And also that way to be able to help decrease the 2 degrees centigrade, increase the temp by end of this century. United States is the one, it produces 16 tons per person. That we have to do it. Some of these, Dr. Ramesh Bajania mentioned about it. Next slide, please. So I want to just highlight. So I think these are all the one top options. 10 of them are there. If you don't use car, you can save 2 tons of carbon dioxide per year. Battery electric car, they save carbon dioxide footprint 1.95 tons. Flight, if you long flight, if you do this one, if you go from Delhi to London, 1 ton of carbon dioxide you produce per person. So long haul travel, one has to be reduced. As a matter of fact, renewable energy, we have to use it. And you can say 1.6 ton. Public transport, 0.98 ton, you are saving. Refurbishment, so how building of the houses contributes to nearly 40%. We have to build up our houses to our need, which can save about 0.895. Vegan diet definitely helps, as a matter of fact. 0.8 tons of carbon dioxide we can save, because vegetarian diet for 1 kg per 1 kg food, a ton. And at the same time, non-vegetarian produces 5 ton to 35 ton per kg per kg of meat. And red meat is the most one. I think it produces 1 kg of red meat produces 35 kg of carbon dioxide. And improved cooking equipment, renewable-based heating, these are all things we have to do in addition to that. Next slide, please. And natural indoor purifiers, these are all the plants, you can keep it 8 or 9 plants and make them to expose to sunlight once a week, remove the tray of water. They are the natural indoor purifier, as a matter. Absorb a lot of formaldehyde, volatile organic compound, carbon dioxide also with sulfur dioxide. Next slide, please. And what the country has been done, National Mission of Clean Air has come there recently. PM announced clean air for all by 15th of August 2020. Last year he mentioned about it. This country want to reduce the suspended particulate matter from 35 to 50% by 2015 to 2026. The base year is 2019 to 20. That included 132 non-attainable cities with a million plus population in India, as a matter of fact. We are spending nearly 6,000 crores to do this, to achieve this goal. Next slide, please. Next slide. I think climate change in India role, PM, I think recently, 22nd of November 2020, G20 or Prime Minister has said, we are inspired by our traditional ethos, living in harmony with the environment. Definitely, the whole of entire world progress faster with the greater support of technology and finance in the developing nations. And in the Paris Accord, we are the signatories 2015. At the same time, we had the future image of the changing our energy from the fossil fuel. That's why we started this International Solar Alliance. It's only two countries started, India and Paris, France. Now we have got nearly 121 countries. And also we are spending nearly up to 175.5 crores of rupees between 2016 to 2021. We are going to get energy 175,000 megawatts renewed energy from next year. Next slide, please. I think, ladies and gentlemen, air pollution, global climate change, what is the way forward? Rich nation owe the government, the developing countries, 1.1 trillion for climate cleanup as promised in the Paris Accord. But earlier something, drawbacks were there. Recently, our Prime Minister addressed G7, he gave that one. They all reaffirmed on 13th of June 2021, they are going to contribute this amount as a matter of fact. Besides, also, they promised to achieve zero greenhouse gases by 2050. And India, also our Prime Minister, they said, in addition to that, 26 million hectares of degraded land to be restored, he said that. And thanks, Mother Earth is smiling because of this, as a matter of fact. Next slide, please. Ladies and gentlemen, the lessons, what we learned during a pandemic, need to be pursued, need to be propagated, and also need to be practiced based on science to save our planet Earth and to save our life from the air pollution. And also, it all depends on educating all the stakeholders and the society. Next slide, please. Ladies and gentlemen, the healthy breath will always bring healthy life. Let each one teach one and plant one tree and maintain it. And I am a positive thinker, optimist. We will overcome air pollution, global warming, climate change in the allotted time frame with the commitment of all the stakeholders. Thank you very much for your time and patient hearing. God bless you all.
Thank you, Paramesh sir, for your excellent deliberation on impact of air pollution, not only on children, but on the whole earth. So since we are running far behind time schedule, we don't have time for discussion. Sorry for that. So, sir, any clarification doubts, kindly put in your chat box. Sir will be answering directly. Thank you, organizers, for giving us this opportunity to chair this session by none other than Paramesh sir. Thank you, sir. Thank you.
Thank you very much, sir. Thank you very much.
Oh, thank you, sir. Thank you, Paramesh.
Thank you, Sukumar. So nice of you. And Nandakumar also. Thank you, sir.
Thank you, Parmesh sir. Thank you for being with us. Even
Jiju,
though you had a
thank
very busy day. Thank you for joining us, sir. Thank you so much, sir.
Thank you,
It's always a pleasure to have you, sir. Now we move on to the last session, sir. I would like to invite, last but not the least, we're very happy we still have 78 participants who are still very hungry to have lunch. So without further ado, I would like to call upon Dr. Nisha, and who is my good friend and a very active member of IAP Kerala, to moderate the session, along with the vibrant secretary of the Environment Chapter, Dr. Naushid. I'm not able to find Dr. Naushid.
Now she's there. Now she's there.
Sir, unmute it.
Galaxy A10. Galaxy A10.
Okay.
Galaxy A10.
Galaxy A10. Okay, I'll just unmute him. 1 second. Over to you, Nisha and Naushid, for the final session of the day.
Thank you. Thank you, Jijo. Next, we have an eminent speaker, Dr. Deepti Pujari, consultant allergy specialist at Divant Mangeshkar Hospital and Research Center, Pune. She attained fellowship in allergy and clinical immunology, and also she is a consultant specialist in allergy specialist in Pujari Multi-Specialty Clinic. She trained from Sheenfield Children's Hospital, UK, and also from JJ Group of Hospitals, Mumbai, and attained fellowship allergy and clinical immunology at Savida Hospital, Chennai. Best of luck, ma'am. Over to you.
Thank you. First of all, I would like to thank IIP Kerala for giving me this opportunity today to speak on immunotherapy. I know I'm the last speaker, everyone must be tired, but my big namaskar to all the dignitaries, Parmesh sir, Sukumaran sir, Joe sir, Ramesh sir, Subramanya sir, Jijo Joseph, Krishna Mohan, and all others I don't want to name because I might miss someone. So thank you one and all. Thank you IIP and IIP Kerala. So today I would be covering some important topics like what is immunotherapy, the basic mechanism, whom to give, when to start, why should we give, what are the benefits, and what are the endpoints? When do you think that immunotherapy has really worked? All these things I'm going to cover in short. I know we are really running out of time and you are all hungry, but I'll try to do my best. I can't start my topic without giving my humble homage and taking blessings from Nagaraju sir, my guru, my mentor, who had taught me immunotherapy and who really did extremely well in this topic. I'll speak whatever he has taught me and from my personal experience. So let me quickly tell you what is the allergic pathway. When are we going to start immunotherapy? So here are the allergens that are entering the body. The best way in allergic practice is to avoid these allergens. That is it. Avoidance, avoidance, avoidance. Let me make it very clear. Allergen specific immunotherapy is not the starting point. We don't start away with it. We first avoid the allergens. But if we are unable to avoid, they enter the body, they enter dendritic cells and taken up by major histocompatibility class 2 receptors and given to naive T cell, where they are taken by T cell receptors, then Th2 pathway gets activated. We all know that interleukin 4, 5, 13 comes, B cells are activated, IgE is produced, and on re-exposure, mast cell degranulation happens when the two adjacent Ig antibodies are cross-linked. And when all these leukotrienes, histamines are released, we get the clinical symptoms. So if avoidance is not possible, second best is give pharmacotherapy. Here we act, we don't let these clinical symptoms appear. So next best is pharmacotherapy. So we give antihistaminics, leukotriene inhibitors, so on and so forth, bronchodilators, steroids, all these to prevent the side effects of these mediators, that is histamines, leukotrienes, etc. Now, if we are unable to give pharmacotherapy also, or there are side effects, or patient is not compliant, then, or we want to prevent the progress of the disease, then we act somewhere in between the entrance of the allergens and the clinical symptoms where the immunotherapy works. So immunotherapy works for all in this pathway. I'll explain you how. So allergy is a trigger for variety of conditions we know. Once an allergic trigger has been identified, management plan will depend on three main factors. Avoidance, as I said, of the triggers, but every time avoidance is not possible. What if there are multiple triggers? What if the pollens are there everywhere around you? You can't avoid. What if pharmacotherapy is not possible? What if there are lots of side effects? What if patient is not compliant? Then we go for immune tolerance, that is immunotherapy. That also we have to see whether it is possible or not. So what is the stepwise approach? Is it easy to avoid allergens? If yes, avoid them. If you are well controlled, no need of immunotherapy. If you cannot avoid the allergens, then try anti-allergic drugs. If you are well controlled, no need of immunotherapy. But even on anti-allergic drugs, if you are not well controlled, then you have to consider immunotherapy. Now in our body, there is a very delicate balance between Th1 and Th2. It is done by T regulatory cells, which is the basis of our immunotherapy. So immune tolerance is lack of immune responsiveness. So we are tolerant. Whom are we tolerating? If we are tolerating self-antigens, we are fine. But the moment we stop tolerating our self-antigens, we get autoimmune diseases. If we are tolerating harmless environmental antigens, we are fine. The moment we stop, we get allergies. So, how is immune tolerance influenced? It is influenced by our genetics, the biggest factor. Nothing can beat genetics. There are almost 51 asthma loci. There are so many genetic factors influencing everything. So genetics really plays a big role. Then route of antigen exposure. We all know that now there is dual antigen exposure theory. If you eat allergens, you eat peanuts early, you develop immunity. But if you apply the same peanut paste on the skin, you tend to be allergic. So route of entry of allergens is very important. That's what also plays a very important role in immunotherapy. Then dose, very minute dose, you will develop tolerance. But if there is a high load of allergen, then you might develop allergies. Time of antigen exposure, very, very important. Nowadays, they are planning to give immunotherapy to pregnant mothers because we want to attack a patient when the Th1, Th2, Th17, Th22, T regulatory cell, all these cell lines are being formed. At that time, we want to enter and give immune tolerance. So that's why the importance of early barn life, vaginal delivery, breast milk, early exposure to pets, early introduction of peanuts and cow's milk. So all these factors, time of antigen exposure, where our body is still giving us natural tolerance, that time if the allergens are exposed, we develop tolerance. But later we might develop, if we are prone to, we might develop allergy. So what are the two types of tolerances we have? Central and peripheral. So central tolerance happens in thymus, that is negative selection happens in thymus, and the cells that are not negatively selected in thymus, they enter the periphery. So as I said, central tolerance occurs in thymus, where the negative selection occurs, deletion of self-reactive T cells occurs, and some cells that escape this central tolerance, they enter the periphery. In the periphery also, the central T regulatory cells naturally occur in our body, and they inhibit the immune, inflammatory and allergy response in the body. If that also escapes, then we develop allergy. So what are we doing in immunotherapy? We are attacking here. We are stimulating this CD4 T regulatory cells, which are FOXP3 type, and these cells then secrete interleukin 10, which is a negative cytokine and transforming growth factor beta, which thereby gives tolerance artificially. So we are more interested in this peripheral immune tolerance, which is otherwise normally also present, but we induce it for a specific allergen to which we are allergic to. So this is it. Once we give immunotherapy artificially, suppose we are allergic to house dust mite, we give house dust mite allergens, they are taken up by the dendritic cells, and major histocompatibility cells are activated. That tetramer gives it to naive T cell, where they are taken up by the T cell receptors. In presence of cytokines, chemokines C28, C2, ligand 9, 7, they form immune tolerance by producing T regulatory cells, which are transcribed by FOXP3. These T regulatory cells secrete interleukin 10. This interleukin 10 is inhibitory cytokine. It inhibits interleukin 4, 5, 13, Th2 pathway. It inhibits mast cell degranulation. It in some way also inhibits Th1, Th17, Th22, though not to a major extent. So the importance of this immunotherapy. Once the T regulatory cells are activated, transforming growth factor beta is also secreted. What does this do? It class switches the B cell in such a way that it no more produces IgE but starts producing IgG4, which is the blocking antibody. So it blocks the mast cell receptors so that IgE cannot act, so mast cell degranulation does not happen. So this is the basic concept of immunotherapy. So what all things we see in immunotherapy, as I already said, I'll not repeat: increase in IgG4, decrease IgE, all these cytokines, histamine release is decreased, regulatory cell increases, and so finally the response of skin, conjunctiva, respiratory mucosa, everything decreases. So what is allergen specific immunotherapy? It is the administration of gradually increasing doses of allergens to which the patient is allergic, reaching a dose which effectively ameliorates the symptoms when the patient is re-exposed to the same antigen. And the beauty is the effect persists even after stopping the immunotherapy. It reduces new allergen sensitization. It prevents disease progression. Very, very important, because this is our aim. We don't want allergic rhinitis to change into asthma. We don't want the grade of asthma to increase. And of course, it improves the quality of life. It brings down the ultimate cost of treatment. So what are the indications? First and foremost is allergic rhinitis. Mostly very effective to house dust mite sensitization, grass, tree and weed pollen sensitization. In foreign countries, they are also doing it for cats, fungi, cockroaches. Mostly in our country, we do for house dust mites and pollens. Same for asthma, for all these house dust mites and pollens. And now GINA guideline has said that as early in step 3, where your asthma is mild to moderate, that time itself start sublingual immunotherapy for pollens and dust mite. GINA guideline has itself said, why not in later stages? Because we don't want disease to progress. We want to halt the progression. Also in Hymenoptera sensitivity, especially in vespid and red ant and honeybee stings. Food allergy, it's best to avoid, but now oral immunotherapy is being done for peanuts, milk and eggs. Here a word of caution: allergen specific immunotherapy should only be offered if asthma is under control. If not, we have to bring it under control. FEV1 should be at least 70% of the predicted. So as I said, what are the indications? The disease has to be IgE mediated. It won't act if it is non-IgE mediated asthma. Then there should be significant symptomatology for significant duration. Avoidance if not possible. There are multiple allergens, new allergens coming. Pharmacotherapy is unsatisfactory. And most important, availability of high potency standardized extracts. We don't want to give chicken soup and prawn soup therapy, which we are seeing a lot in our country. It has to be standardized allergen extracts in appropriate dosages and in compliant patient, because immunotherapy has to be given for 3 to 5 years. Otherwise, it will ultimately lead to failure. So what are the types? Subcutaneous, sublingual, epicutaneous, oral and intralymphatic. We mostly do subcutaneous and sublingual in our country. Which route should we choose? First of all, allergenic extract availability is the major issue. Are we getting those extracts? Is subcutaneous allergen extract available? If yes, then what about the physician and the patient? Is the patient ready to come? Because sublingual immunotherapy can be taken at home. For subcutaneous immunotherapy, the patient has to come to your clinic, wait for half an hour. So there are lots of patient preferences, logistics, geographical location, and whether patient is able to adhere to the regimen. So what is the schedule? There is build-up phase and maintenance phase. Build-up phase can be conventional, cluster or rush. So can you see these 5 bottles of subcutaneous immunotherapy? Depending on the initial size of the wheal and flare of your skin prick test and serum specific IgE for that particular allergen, you take the initial dose. If the initial reaction was very high, you would tend to go slow. Your initial dilution will be very high. So you can see here, it is 1 in 1 lakh. You give 0.05 ml, then you can increase to 0.1, 0.2, 0.3, twice a week injection, slowly 1 is to 10 lakh, 1,000, 100 and 1 is to 10. serial dilutions with increasing concentration and increasing strength twice a week in conventional schedule, which takes almost 4 to 6 months. In cluster, it takes 6 weeks, and rush immunotherapy build-up phase can happen even in 3 to 6 days, especially if patient is coming from outside. In conventional, we tend to lose patients because they get fed up, and cluster is considered quite best, but cluster and rush have a lot of side effects. We have to be prepared. Patient might need to be pre-medicated with antihistamines and steroids, and only then these schedules should be given. And then the maintenance phase, twice a month or once a month, to be given at least for 3 to 5 years. Otherwise, immunotherapy won't be a success. So subcutaneous immunotherapy, it is not to be done in food allergies, urticaria, or anaphylaxis, because there are chances of side effects and producing urticaria itself and anaphylaxis. Best outcome, I have already said, for house dust mites, pollens, cockroaches, and fungi. We need not mix, because the best practice is use single major allergen, because one proteases from one allergen could degrade the proteins of the other allergen, and we won't know what exact quantity we are giving. So there could be failure of immunotherapy. There are definitely local side effects, erythema, swelling. We have to just apply pressure for 5 to 10 minutes. You can use ice packs, local antihistamines, steroids. We have to make patient wait for at least half an hour in a clinic to look for any side effects. Anaphylaxis has been extremely rare, 0.1% worldwide incidence, though local side effect is almost 60 to 70%, especially when we open the new bottle. And double-blind placebo-controlled trials for up to 7 years after stopping immunotherapy have shown almost 30% greater improvement in combined symptom medication score. I'll tell you what is symptom medication score. Now the sublingual, it is safe, very convenient, can be taken by the patient at home, but the dose is very high, almost 50 to 200 times. There are some local side effects, itching, swelling, tongue, palate and uvula can be swollen. There could be itching of the pinna, but these are very mild, mostly for initial 2 to 3 weeks, and then patients grow out of it. Very safe, can be done in patient's own convenience at home. It's mostly used in allergic rhinitis, asthma, and rhinoconjunctivitis. Again, double-blind placebo control has shown a very good effect. But the drawback is there are still standardized allergens are not available in our country. Oral immunotherapy is only done for food. Best is food avoidance. But if you cannot avoid food, or if we want to prevent anaphylaxis or accidental exposure, or we want to introduce allergenic foods in normal diet, so we give oral immunotherapy. Here the food allergen like peanut powder is given along with some vehicle. Slowly increasing doses, right, starting from 0.1 ml, 1 ml, 2, 3, 4 ml, we slowly increase and reach a satisfactory dose. Suppose milk, a patient starts consuming 100 ml milk, which is quite satisfactory. In desensitization, patient has to continue consuming that 100 ml milk every day. The moment patient stops doing that, he might again develop the allergy. And in immune tolerance, even if the patient stops consuming milk, he will still continue to be tolerant to milk. So there are lots of studies still going on. How come that some patients remain desensitized and some become tolerant? There are several unmet answers to it. Having said that, we have to remember, while we are on this therapy, avoidance has to be done. Avoidance is still the best. But if there is accidental exposure, we don't want anaphylaxis. That's why we are giving this food oral immunotherapy. Now there are some other routes like intralymphatic. I'll be quick because we are extremely late. Dose is extremely low because we are directly giving into the lymph nodes. So just 3 injections are equal to 3 years of subcutaneous immunotherapy. Very good results with some side effects, but we are not practicing in our country. Then these are some other routes. I will not go in detail. So what are the advances in immunotherapy now? Allergoids. These are allergenic proteins which are cross-linked with glutaraldehyde, making a polymer. So polymer being a larger molecule, it retains its ability to stimulate T regulatory cells, that is its immunogenicity, but it has less allergenicity because only two ends of the large molecule are available for reaction. All the inside molecules are linked to each other and not allergenic. So advantages are rapid buildup regimes, delivery of large amounts of allergen, few injections, decreased binding to Ig, so decreased side effects. But again, we don't have allergoids freely available in our country. So we are still long way behind. Then there are mucoadhesive molecules, which again, lesser amounts can be used. So frequency can be decreased and less side effects. Recombinant allergens can be produced like vaccines. They can be cloned, and good standardized allergens in unlimited production can be done. Still under not available in our country, but in foreign countries, they are using it for ragweed, timothy grass, and cat danders with excellent results because they are hypoallergenic allergens. So what is this combined score of what is the end point? What is the end point of immunotherapy? How do we know whether it has worked? So what World Allergy Organization has given, it is said that do combined symptom medication score. So what is it? For symptoms, we take rhinoconjunctivitis. Rhinitis like itchy nose, runny nose, sneezing, nasal blockage. We give if the symptoms are absent, mild, moderate, or severe after finishing immunotherapy. And conjunctival symptoms like itchy red eyes and eye swelling. Again, depending on the symptoms, they are given source. Suppose a patient has mild symptoms of nasal symptoms and eye symptoms and his total score is 6. So 6 divided by 6 is 1. So his total symptom score will be 1. Total medication score, whether you are using oral or topical antihistamines, 1. Intranasal steroids are required, 2. Oral steroids are required, the score would be 3. So total 6. Suppose patient requires only oral antihistamines, score would be 1. So 1 for total symptom score, 1 for total medical score, total would be 1 plus 1, 2. So anything below 3 is considered very good. Other methods to see whether our allergen immunotherapy has worked is allergen provocation testing, environmental exposure chambers. Patient is put in a standardized environmental allergens are put in that chamber so that fixed exposure can be given. Or the best, what we practice is visual analog scale. We just tell patient to tell what is his symptom score in the score of 0 to 10. That is how we monitor clinically in our practice. When do we say it is failed? Immunotherapy is failed where there is no improvement even after 12 months of continuous maintenance therapy. And what could be the causes? New allergen exposure. We are treating for house dust mite. Patient brings home a cat which he is very allergic to. Your immunotherapy will fail. Or new allergy sensitization has happened. Again, there are lots of pollens. New pollens are getting sensitized. Incorrect diagnosis. The patient was not even allergic rhinitis, the patient was to begin with having non-allergic asthma, non-allergic rhinitis, and you thought it is allergic and you started. And patient misunderstood, of course. You have to make sure that you tell your patients that it is not complete cure. It is just decrease in the symptoms, improve quality of life. Patient can still have 1 or 2 sneezes here and there. So patient should be told and counseled properly. So there are a lot of research scope. We need more of hypoallergens. We need more of adjuvants. We need more of vaccines in this field, which is not in the scope of today's talk. So what is my take home message? Allergen immunotherapy develops allergen specific immune tolerance. Effect persists even on stopping the therapy. It improves the symptom medication use, quality of life, and is cost effective. Patient selection is very important. Standardized allergens are the key to successful treatment. We shouldn't give prawn soup therapy. We have to use standardized allergens. Thank you.
Thank you, Dr. Deepti, for the excellent, concise, information-packed talk, which is useful for pediatricians and allergists alike, actually. And we got quite a lot of points from, which was crisp, actually, points from your talk, including the stimulation of Treg cell leading to IL-10 and TGF-beta production, Ultimately, both these are decreasing mast cell degranulation. One is by blocking antibodies, etc. The different schedules, when you should use allergic rhinitis and FEV1 more than 70% is a must according to GINA. Then you talked about the newer advances and also about the combined symptom and medication scores to monitor and reach the endpoint and when it fails. Altogether, it was a good experience. Thank you so much for the wonderful talk. Okay, and I thank IAP Pathanamthitta for the great opportunity I got to spend this Sunday in this wonderful CME. Very well organized. Thank you so much.
Thank you, Deepthi. And thank you, Nisha and Naushid, for the excellent moderation. We believe we have come to the end of the session for today. We have had a very long day. We thank all the participants for being with us till the very end. We have more than 65 participants till the last talk also. We thank all our speakers who happily joined us without any deliberations. The moment we asked, they were very happy to join us and been with us from the beginning till the end of the talk. With these words, I would like to wind up for the session and all of you have a happy Sunday. Take care. Stay healthy.